All right. So it looks like I thought we could do both, but it looks like it's just one. So I'm live on YouTube.
Okay.
So I'm gonna paste the link in the chat so that everybody can share.
Okay.
I thought you could do multiple. I guess that's the benefit of those StreamYards and those.
Yeah, man. We work it out.
Yep, we good. All right. So Chris, how long have you been practicing?
Ooh, so graduated med school in 2001 and graduated fellowship in 2006.
Okay.
Yep. So about 15 years. Yeah, about 15 years.
Okay.
So been out there a little while.
Yeah. Yeah. What made you want to even go into medicine?
Honestly, it's a little bit of a quirk. So I was graduating high school, had not made summer plans, and was from a small town, rural town. So typically we just work in fields or whatever we can find in a small town, and was late to go to North Carolina A&T, and they had a program that was for getting minorities into the healthcare fields.
Okay.
And they did not have enough men. So my guidance counselor called me up, said, "Hey, are you interested in medicine?" At the time, I actually just wanted to be a school teacher.
Okay.
She was like, "Well, there's this program, it's got a stipend," and I was like, "Sign me up." So like just anything to keep me going home.
Yeah.
And so went there and had a really good experience there. So so completed that one. Got to shadow actually it was a Black surgeon that was in town. Had a really good experience, and kind of got my curiosity at that point in time.
Uh-huh.
And there was another program about 2 years later that kind of introduced you to like the testing and stuff you needed in order to get into med school. So did that one, scored reasonably well. I actually scored well, and kind of made a decision to switch from teaching to medicine.
Okay.
That's what really kind of it was kind of a little more of a gradual thing for me. I wasn't one of those people that wanted to be a doctor at 5. It was just some exposure, basically.
Yeah. Okay. Well, we're going to get started soon. I see some attendees joining in, so we're going to get started in just a few minutes. And we'll jump right into it. We'll turn it over to our host.
Sweet.
Sir. Yes, sir. It's amazing how God works with those things, huh?
Yes, it is. Yes, it is. Because I mean, and honestly, there was another thing because I was in in college for,
Uh-huh.
like for teaching. It was like part of it was a teaching fellows program. And it just so happened, I think, because I was at A&T and, our program directors were, honestly, looking back on it, they were much more, they wanted us to become teachers, but they were more interested in us developing ourselves and, becoming whatever, like they would not shy away from saying, well, if you're interested in something else, kind of pushing you towards that. And I will never forget, I had actually applied and was accepted to med school, but of course, I was in this scholarship program where I told them I was going to become a teacher. And it was Dr. Josephine Lux. She was our program director. And I was like, I'm like, I don't know what I should do. I didn't sign this thing saying I'm supposed to become a school teacher. And I will never forget the look. She just looked at me. She's like, what are you talking about? Go teach medical students somewhere. So it was, I mean, for her, it was this, I guess she was looking at this country bumpkin, like, how are you making a decision between a teacher and becoming a doctor? And but she was probably she was really one of the reasons why I went, because otherwise I'd have probably just, yeah, teaching is great, but she just showed you that you can do more. You can do what you want with medicine. So, you're teaching students, you're teaching patients, you're teaching a lot of people all the time. So, so like you said, it was just, God's grace. Because like if I was somewhere else, or if I had not, if that wasn't my the person of our program, yeah, I very easily could have not gone this path. So
Right. The funny thing is, I believe a lot of HBCUs are built that way.
they are.
That you get there and you think you're gonna do something, and they'll show you, and they be like, "Hold on, you don't have to do this. You can do this. It's not. It's never
Yeah.
on you." Yeah.
Exactly. Because I think, you're around a lot more people that, well, I mean, you just have conversations with them.
Yeah.
And as you're talking to them, it's kind of like if I'm talking to a young black male, I
Mm-hmm.
know what background, what kind of limitations there are that they may have come from.
Right.
And I think they did the same thing. They're like, okay, I know you're not even thinking about, you don't even realize the impact of the decision you're about to make.
Right.
And I think that goes a long way. And so like that HBCU connection, it was just having just an increased chance of running into somebody that knows what you're going through. So
Yeah.
it's huge.
I had a similar situation with, and he actually happened to be a new brother Jack Williams, where he pulled me to the side, like, "What are you doing?"
Right.
At that conversation. So it's like, "Hey, you DJing, doing all these parties, that's a real business. I really didn't look at it that way." He's like, "You operating, functioning in a business. Let me show you this. Let me show you the way." And I was like, and he took me out. He didn't know I could golf. We golfed together. We did all types of stuff. We started the golf team at Google Course.
Mm-hmm.
We did lots of different things, but he showed me the same way. I didn't know what I was going to do. I was like, "All right, cool. I'm here. Let me just finish up, do what I'm going to do, and I'll do something in business." He's like, "Well, you're a great marketer. So why don't you go into marketing?" I'm like, "Well, I want to do finance." He's like, "But right now what you're doing is marketing. You know that?" I'm like, "Nah." So
All right. Like, I don't know what it is.
and showed me. I'll never forget it. It was like night and day, and that switch clicked in my head. Like, oh,
Right.
wow, I can really do this.
Yeah. It's like you don't know what you don't know. I mean, it's just
Right.
these different worlds out there. So and just someone to push you a little bit in that direction. A nudge. The nudge.
The nudge helped a lot.
Exactly.
Hold up.
All right, we ready?
Ready.
All right.
All right. All right. Good morning, everybody. Good morning. Welcome to the Men's Virtual Health Forum. This is first of many. I am Dominique Chapman. You might know me also as Dommy Styles from Power 107.5, 106.3, all the Radio 1 family and everything else. And I am honored to be here and blessed to be here with some phenomenal people. I have Mr. Marcus Baylor with me. We have Dr. Chris Brown. We have Columbus Black. We have TLC. We have numerous people that we are here to talk about men's health. This is the first one of many to come. And I'm happy and honored for everybody who's on here and who's willing to listen, to take a little bit of time out of their morning to make it better them. I'll give you a little background about myself. The reason why I'm here is I am a living testimony of once you get your mind together and your mind right, you start feeling better. I was overweight. A lot of people see my D40 campaign where I was going to lose 40 pounds for my 40th birthday. And I lost the 40 pounds plus, which was an amazing thing. But after that, after the campaign, I wasn't accountable, and I ended up gaining all the way back and some. I look back at those times, and it's like, wow, I was where I wanted to be. What happened? What happened was life happened, and it happens to a lot of us. And to be honest, I've always been Dommy Styles, so my lifestyle of eating and nutrition and going to see my doctor has never been the way it should have been. And one day, I lost more than a couple of good friends of mine to health issues, and being 40, it's like, wow, they're gone too young. And I woke up, I have two beautiful boys, 7-year-old twins, Jackson and Cassius. I have a beautiful wife. And at one point you had to look inside yourself and be like, I need to make this change. So I went out, I reached out to some people that I knew who were in the health field, and I decided to make that switch. Once I made the switch, I'm back on my journey now. I found out from Brother Bailey. He I know he was doing this thing, and I was like, Marcus, I need help. What should I do? What supplement should I take? I know about vitamin D, but I don't know about vitamin D. He sent me a lot of information, like, try this. It helped. Brother Brown, I was like, Brother Brown, I need a family practitioner. I need somebody who's like me, because when it comes from somebody who is of my tone, and when it comes from somebody who's African American, it comes off a lot easier for me as a Black male, where I can relate and be like, okay, this person knows what this is. It just brings validity to it. So that being said, my journey is started. I'm eating better. When I started eating better, I started feeling better. When I started taking some vitamins, I started feeling better. There's little changes that made a major difference. When I went to the doctor, got my numbers, and Dr. Brown's helped me find a new doctor now, because I'm still one of those guys. I don't trust doctors, just from a lot of things that I've been through. Dr. Brown has helped me get through that part of it, and I'm finding a new doctor now. I'm going to get my new numbers so I can have my blood pressure, see my blood pressure is going to break. Because if you don't know, there's a lot of silent killers out here that's affecting our communities, that are affecting Black men, and it's not necessary. It's not genetic. You just have to make that switch. And we're here not to preach to you, but we're here to to talk with you and dispel some of those issues and some of those rumors, and answer some of those questions that you might have, because I know it's going to be a lot better. It's a lot easier coming from us than coming from somebody else. And we're here just to help out our community. So we'll be talking about different things throughout today. Like I said, we have two great panelists right here that are going to drop a whole lot of knowledge on you. And the first panelist is going to be Dr. Chris Brown, and he's going to talk about your family practitioners dispute, get rid of some of these myths that we have, like I don't need to go to the doctor, or how do I find my family practitioner? What is a family practitioner? Should I have a general doctor? Should I have a specialist? Dr. Brown is the man for that, and I'm honored to introduce him to our the first, panelist on our panel today, Dr. Chris Brown.
All right. Thank you, Dommy. Thank you for that. Thank you for that great introduction, and for your testimony. I mean, I think that sharing your story is huge, and a great way to make a connection with other men. Sometimes I think a lot of times as men, we think, what are we going through is unique to us, and that nobody's going through it. But I think whenever we share these stories, we realize that we're not alone, and that other people have similar struggles, and they can and sharing that you're not alone, but you also find ways to address issues that you may have. Kind of like you said, I mean, if you're not having a good primary care experience, and you talk to somebody else and say, hey, my primary care is great. Let me give you that name. Then like I said, that is information that's being shared. And like I said, a lot of times, like I said, the information that we get, it doesn't always come from books. It comes from other people, from conversations that you have. So I think that that's huge. And so what I'm going to be providing for you, I think some people may think it's a little boring, but I'm going to share with you all information about, primary care, what primary care is, and also the physical exam. And, while these terms are kind of simple, one thing I've found over the years is that, they mean a lot of different things to a lot of different people. And sometimes people don't understand, kind of the importance of these, relatively simple terms, and also don't understand, how important that is to your health. So we're going to go through a couple of slides here. I'm going to share the screen. Let's see. That's the right one there. All right. Okay. So primary care and the physical exam, we're just going to talk about why this is important to you. Okay. And so I am Dr. Christopher Brown. I'm actually a kidney specialist, kidney and hypertension specialist. I actually practice down in Chillicothe, Ohio, but I also have a small hypertension clinic here in Westerville as well. I do have a website, thedocbrown.com, if you want to kind of go there. And get some information, general health information. Most of it, of course, is about kidneys. But that's kind of my background. I'm originally from North Carolina, been up in Ohio now for about 20 years. And I saw that joke from Perry, but that's all right. But but I've been up here for about 20 years, a lot longer than I would have thought. Also have two children. I have two daughters, two really young ladies now. So they're kind of growing. So of course, healthcare is very, very important to me here. So of course, as a disclaimer, this presentation is educational and is not medical advice. So I always tell people that, even though I'm a doctor, I'm not your doctor. So if you have specific concerns regarding your personal health, then, make sure that you schedule a visit with a healthcare provider or healthcare clinician to address your particular issues. Okay. And so primary care. So one of the things that a word that's tossed around a lot is primary care. So the question is, what is primary care? And and in primary care, the patient is central. And what you have to think about is, the services that are being provided to the patient, the practice that a patient will be going to, and then also the clinicians, the type of clinicians that will be providing the services that this person will need. So when we talk about primary care services, we're talking about, kind of routine care. So where the place you would go to get your annual, your physicals, like I said, hey, I got I was out playing and I kind of twisted my ankle, you could go there first. It's really, and some people actually call it, kind of your medical home, kind of your first place to go to in order to get any sort of health issues addressed. And so those services are, like I said, these evaluations, management, they also can refer, some of the services is to refer you to specialists. And depending on what type of insurance you have, sometimes you have to have a primary care clinician before you can either be referred from an insurance standpoint or before a specialist will accept you. They won't accept you just going calling them up and setting up an appointment. They say, no, who's your primary care clinician? And some people get upset at that, but the reason is that if you go to that specialist and you don't have a primary care clinician, you know yes, you may come to me for your kidney issue or whatever, but if you got diabetes and stuff of the nature, I'm not going to manage that. Your primary clinician is going to manage that. And so all these services are there. So, and then you got a primary care practice, and this is really that home area. So like I said, these services are provided within a primary care practice, and there are a couple of different practice styles that are there, what you can kind of differentiate based off of how you pay for those services within that practice. And I'll go through that a little bit later on. And then we talk about the person that's providing the care. So you got primary care physicians, and the primary care physicians are family practice physicians. You got internal medicine physicians. Pediatrics are primary care physicians for people under the age of 18. They actually have something called med-peds, which is internal medicine and pediatrics. These are doctors that train in both areas, and they go out and they practice for both of those. And then you also have actually OBGYNs can serve as primary care physicians for women. And then you also there are some specialists that will serve or provide primary care services. Actually, as a nephrologist or kidney specialist, we used to do this for whenever a patient would go on dialysis, because we would see them so often. Sometimes we would become their primary. We would also become their primary care clinician as well. And but that was kind of back in the day. Now most of us will provide subspecialty services, and we'll let the primary care doc provide the primary care services. And the reason for that is because as healthcare becomes more and more complex, as you need certain things and as you need certain evaluations, it's easier for that to be provided by that primary care clinician than it is for me to try to provide this special care, as well as look out for your overall health. So, but there are some specialists that still, especially for some of the older ones, that will still provide that total care for you, even though they're not a primary care physician. Then you also have non-primary care physicians, providing primary care, which is what we talked about already. And then there's non-physician primary care providers. And these are the nurse practitioners and physician assistants. And we'll kind of go into that a little bit later on, but they provide primary care, but they're not physicians. So I always say it's important for people to recognize that exists. Okay, so going back to who can provide care and just kind of going into that a little bit deeper. So kind of like we said, we got physician and doctors, we got nurse practitioners, and we also got physician assistants. So the physician assistants and nurse practitioners are sometimes grouped up under what we call physician extenders. And the original thought behind this is that they would kind of provide assistance in that physician carrying out, care for a particular patient. So originally when it started out, what you would do is you would see your physician, and then, like I said, after they establish a plan of care, then, like I said, then you might follow up with either the nurse practitioner or physician assistant. For the physician assistant, that's still pretty much how this works. But like with the nurse practitioners, it varies depending upon what state you're in. There are some states where nurse practitioners can come out of their training. They can go out and they can set up a practice and practice completely independent. They don't have to be associated with a physician at all. Here in Ohio, however, there is a requirement that the nurse practitioner has what we call a collaborating physician. So they have to practice basically up under a physician's license. So even if that nurse practitioner is out with his or her own practice, there's a collaborative agreement, so that if there's an issue that needs to be addressed, that nurse practitioner can reach out and ask that physician to kind of collaborate on more complicated cases. In terms of training, the physicians, so you do 4 years of undergrad, 4 years med school, and then for primary care, you do at least 3 years of postgraduate training, basically. So you have to do that. Then you have to do boards and things of this nature. The nurse practitioners and really physician assistant, these are degrees that you get after your 4-year degree. So the nurse practitioners, most of them are nurses first, and then they go on to get anywhere from 2 to 4 years of training before they go out to practice. But you don't have to be a nurse. Like I said, some of them have 4-year degrees in other areas, and then they go get training for nurse practitioner, and then they go out for practice. Physician assistant, same thing. So like I said, you get a 4-year degree, then you go in for that. Usually, I think it's 2 to 3 years of training, and then you can go out into practice. Okay. So now we're going to go into different types of primary care practices. And the reason I would decide to go over this issue is because, when you typically say primary care or primary care practice, most people think of, get my insurance card, I'm going to, set up my appointment, I'm going to go in here and, my doc's going to take my insurance and, and go that route. And honestly, that's the majority of practices that are out there. You take your insurance card and pay your copay if there is one, and you kind of go about that. And then the other one I think people at least have heard about is what we call concierge practice, which is, I have a whole lot of money, I pay my fee, and my doctor goes where, like when I need my doctor finds me. So these are going to be much more lush practices. You're going to, like I said, some of them take insurances, some of them don't. But typically there's some sort of fee that's associated with enhanced access to the to that clinician. So whether it's night access or, like I said, they come to your home or something in nature, that will be defined by that particular practice. But those practices are out there. And then there's something that I've found is not as well known, and it's called direct primary care. Sometimes we call them cash clinics. And this is something that I think people really need to be aware of that's out there. Because when they hear cash clinic or cash clinic and things of this nature, most people are thinking concierge. They're thinking high prices and stuff of this nature. But direct primary care actually, a lot of times is, actually quite affordable. A lot of times these docs don't take insurance at all. And what they do is they charge a membership fee. And that membership fee I've seen as low as $35 a month. Sometimes, like I said, 35 up to, I don't think I've seen anything over about 150, at least from what I've seen. And it's a monthly fee that you have, and it usually will cover a certain amount of visits. So it may cover 2 or 3 visits a year based off of that fee. But what happens is that with this direct care model, that physician will have fewer patients. So in these traditional insurance models, that primary care doc may be covering anywhere from 3,000 to 5,000 lives of people that are on their panel. The direct primary care, a lot of times they may have 300. Some at most of them won't go above 500 patients. And what they do is they have, they'll have a lot more time to spend because they just have fewer patients. A lot of times they may even give you they home number. I'm not doing that. I'm just letting you know. But yeah, they will get now. They may give you their home number. They'll tell you what hours they have set. And things of this nature. And so it's a different model of primary care that people can access. And so a lot of times people say, oh, well, I don't know if I want to pay that, but think about your cable bill. And how much you pay for your cable bill. Like I said, if it's if you can get direct access for $40-$50 a month, this may be better. Sometimes they'll have different hours. So they may be in their clinic until 7 o'clock in the evening. So therefore you don't have to take out work in order to go see the doc. So it's just something to think about. And I always like to make sure people are aware that this type of practice is out there, because they seem to be, at least from what I can tell, they seem to be growing and becoming a lot more prevalent. And so, you know, when you're looking for primary care clinicians, make sure that this is one of the ones that you look into as well. Okay. Okay. All right. And okay, so and then we come to the issue of, you know, why do I need a primary care clinician? Why do I need to sign up? I'm 30 years old, I'm healthy, you know, why do I need anything? And one of the biggest reasons is because of lower costs of care. And so most people don't really think about it, you know, but if you go to the emergency room, you know, the average emergency room cost is going to run you, you know, like around $1,200. Urgent care is 155, whereas average primary care copay is going to be anywhere from 20 to $40. So whether that's, you know, you start wheezing for some reason, you sprain your ankle, you know, you can always get an appointment with a primary care clinician that you've already established with. So that's the one thing. It's like if you're already established, then it's easier to get in. And I think this is something that people are not aware of. So if you're seeing your physician on an annual basis, maybe once every 1 to 2 years, you know, you're what we call an established patient. So we know you. So when you call, you don't need to, you know, you don't have to fill out a whole lot of, well, you got to fill out some forms, but not as many forms. We can find more places to fit you into the schedule, so that if you have things that are urgent, not emergent, of course, emergent, still got to go to the emergency room, but urgent issues, you can come in, and we can find some space for you to come in and take care of that particular issue. And I'll tell you, you know, so for one thing that I see frequently, and that is hypertension. So say that you go to, you know, African American Men's Wellness Wall, they're doing screenings. You go over there and they find that your blood pressure is 200 over, you know, 110, but you don't have any symptoms, you're fine. So now if they send you to the emergency room, you're going to get tagged with this bill right here. But if you go to your primary care clinician, they're going to go and evaluate this, get you on some medications. Granted, at the same time, they should have already known your blood pressure is high, but that's another story. But, you know, they're going to go ahead, you know, you're going to pay this $20 copay. They're going to see you. They're going to manage what you're going to be doing. Because in the emergency room, they're only going to treat you if you have some emergent condition, headaches, chest pain, something of that nature. And they may or may not put you on a medication. And they're going to tell you to go to your primary care clinicians. So this is one of the reasons why it's very important for this for us to make sure that we have primary care clinicians. Other reasons are to help navigate the health system. Yet again, so you come in there with a particular issue, and so it's a sprained ankle. Maybe the primary care clinician doesn't do a lot of musculoskeletal stuff, but they refer to an orthopedic surgeon that they've had great work with. And so they can help navigate that. Or maybe they say, oh, you don't need an orthopedic surgeon. You know, we got another specialist over here that might be much more appropriate. So the primary care clinician is kind of your guide in here. So they can help decide, you know, what issues you have that can be managed on what we call an outpatient basis, or basically in clinic, or what issues might need hospitalization. So they can kind of help navigate that sort of stuff. Whereas if you go to the emergency room, you know, they're really looking to see, you know, whether or not, you know, this is something that's emergent and things of nature. And like I said, a lot of times they wind up sending you back to the primary care doc in the first place. Also, you know, it's like I said, so we can decrease these ER and hospital visits. The other thing is you want to catch your health issues early, whether it's blood pressure, diabetes. You know, they can evaluate, you know, see if you got what we call carotid stenosis, where the arteries are narrowing. You know, you can catch a lot of diseases pretty early if you have routine visits with your clinician. And a lot of these diseases, if you find them early, you can manage them better. And so that you don't get, you know, in what we call for hypertension, end organ damage. From a lot of these diseases. So you want to catch things early, treat it early, so that you have, you know, less sequelae or less results from disease. And then also to improve patient-clinician communication. So, and this is another thing that a lot of people don't recognize. So if you say you need a cardiologist for some reason, now if you go through your primary care clinician and they refer you to a cardiologist and you have a bad experience, you go back to your primary care doc and say, hey, you know what? I had a horrible experience over there. Guess what that primary care doc does from then on? he's either going to call him up, say, hey, what happened over there? Or they're going to refer to another cardiologist. The cardiologist that had an attitude is not going to want to lose that business. So, and because what's going to happen is that not only am I going to refer you to somebody else, but all the rest of my patients are going to go to the cardiologist that gave my patient good service. So it kind of helps with that. And then it also helps to explain things. So like I said, maybe what you were upset about was that the cardiologist gave you a diagnosis. And when you come back to the doc that you already know, they help explain this a little bit better. So this can kind of help improve, the communication between you and not only that primary care physician, but also any specialists that you may have. And then also answer any questions you may have. Like I said, as things come up, like, hey, like I said, I had this itch on my knee. They can help. They can help you with navigating it and taking care of those sort of things. Okay, so that's kind of running over, the primary care and kind of what it is and the different elements that are in there. So one of the I would call the quintessential or the most important things that your primary care clinician is going to do is called the physical exam. Some people call it the annual exam, checkup, things of this nature. The importance of the physical examination is to screen for disease and assess for risk factors for disease, basically catching things early. That's what we want to do there. Now, there is controversy as to how often this is needed for healthy people. So if you are, so yet again, 30 years old, you're, like I said, you're otherwise healthy as far as you know of, and, there's no risk factors, then, do you need to go every year? Probably not. But typically most people will recommend anywhere from 2 to 5 years if you don't have any risk factors, which for African Americans, there are very few of us that don't have any risk factors because family history counts as a risk factor. So that's for, that's in terms of the recommendation. But I also let people know that is, if you go more than 3 years without seeing that primary care clinician, you become a new patient. So whatever spot you had will be lost and there will be someone else to fill it in. So the next time you come see them, you have to do what they call reestablish. So you have to fill out all the questionnaires. You have to get the longer visit if you wind up not seeing your doc for more than 3 years. So typically anywhere from 2 to 5 years is recommended, but you want to see them, even if you're otherwise healthy, at least every 2 to 3 years, just to maintain your spot there. And then also remember that for most insurances, a lot of times that annual exam is of no cost to you. So it's free. As a matter of fact, you've already paid for it because you pay for the insurance. So you might as well use it. Go there, make sure you maintain that good relationship. Ask it, like if you got some questions that have been burning, write them down and take them with you. Okay. So that's it for that physical exam. Okay. So, the common types of physical examination, this is something that I did find out that people didn't know. So like I said, you go to your doc, there's a routine or sometimes, more of a comprehensive physical exam, but you also have insurance examinations, pre-employment or occupational exams. So what I found is that some people were getting, kind of occupational exams. So say you're a trucker, you may be getting certain things evaluated, but you may not be getting the proper screening. So like for your prostate, because the trucking industry doesn't need to know what your prostate is. But if you had a routine exam with your primary care clinician, they would cover those sort of things. Part of what we do and what they do in primary care is there's actually an organization called the United States Preventive Services Task Force, where they pretty much do a lot of rigorous research, and they say, hey, for a 30-year-old, you need to be checking, glucose, you need to be checking cholesterol, you need to be checking, whatever, a number of other different things. For a 50-year-old African American man, you need to make sure we got a PSA there. We need to check that prostate out. If they have a smoking history, we need to get CAT scans. And so this is in the realm of the primary care specialist. And one of the reasons why we want to get that done. And so the exam that they're going to be doing is going to be a lot different than the one you're going to get either from an insurer or from an occupational person. So I always like to let people know this, because I've had a couple of times where people, they were getting their work exams, but they didn't realize that they weren't getting that comprehensive exam that they need. Okay. So when we do this, what are we doing? So we're doing what we call a history and physical. So what the history is a series of questions about your health, and that helps determine if a disease process may be present. So you're going to come in, they do something called a history of present illness. Hey, why are you here? Yeah, well, I'm just here for routine. Anything going on? Well, other than this, this little dry skin, I think I'm doing fine. Or, it may be, yeah, because I've had this before, like, yeah, I'm doing okay. Other than at work, every now and then I have to sit down because I get this little, I don't know, it just feels a little weird over here. So these sort of issues come up, when they're asking you these questions. And based off that, we'll determine, so what sort of testing and imaging I'll get later on. So that's the history of present illness. And then the medication. So like when you go and they ask what medications, any medication that you have, whether it's prescribed or over the counter, needs to be presented to your clinician. Okay. So if it's supplements, that's fine. I mean, some clinicians believe in supplements, some of them don't, but it doesn't matter. You need to list them all. You need to have a list of all of them and take them and let them know that you're taking them, whether or not you're taking them every day. I'm supposed to be taking them every day, but I don't. I take this once a month. Just let them know what's there, because if something comes up either in your blood work or you have some sort of issues, like I said, we need to know that you are taking certain things, because there's certain medications, like stuff like, I think it's ginkgo biloba, that can do a little bit of blood thinning. So those things need to be known. So I always tell people to, like I said, write down everything they have, herbal remedies, whatever you got from your great aunt Tessie, put that stuff down and make sure that it's known. Then, of course, allergies, which is kind of self-explanatory. If you've had any reactions, we need to know that stuff. Family history is probably one of the more important ones, because knowing that family history can help predict what sort of diseases you're at risk of developing. So if it's heart issues, if it's, diabetes, obesity, sometimes if you could just tell them, say, hey, I don't know, like, so all the men in my family died at, 55. That's huge. And it can cover a number of different things. It may be heart issues, it may be seizures, it may be, a lot of other things. But that should trigger something in that clinician to be aware of that. If you're a 30-year-old somebody, and maybe you'll get some screenings at the age of 40, as opposed to waiting till you're 60, which may be what our recommendations say. Social history. So we want to know if you're smoking, if you're drinking, if you got, you light up a blunt, all that stuff. All that stuff is included in the social history. A lot of times they'll also obtain information about, your occupation, because if you're in areas where there might be, people aren't exposed to asbestos or anything of that nature now. But a lot of times we like to find this out. So with our older patients, if they did get exposed, there's certain diseases that are more prevalent in people in certain occupations. So like I said, all that stuff is there. And then a review of systems is just kind of like it says. We go through all your systems, like I said, your vision, your smell, your taste, anything going on in your neck. You got any chest pain, any nausea, vomiting, any blood anywhere. So they go through an exhaustive list. Most of the time, they'll send you a slip of paper before you come, so that you can fill a lot of that stuff out. And it's actually really important that you fill that out as much as possible. And then what they'll do is, like, when you come there, they'll go through it to kind of clarify any issues that might be there. Okay. Then next, we have what we call the physical, actual examination of the body. The first time it's done, it should be a head to toe exam. One of the things for, when you're establishing with a physician, is that they should have you get out and into a gown. A good primary care clinician will have you get into a gown in order to do your exam. And the reason for this is, number one, it's easier to do most of your exam. The other thing is this, and that is, part of this is looking at the skin, just making sure they're not certain lesions. Stuff like melanoma and stuff of nature that pop up. And if you're in your clothes, they can't see that. And this becomes important, especially for us, because, we ain't, it's kind of hard to see, certain lesions because we got a lot more pigment. So like I said, that primary care clinician should be getting you out at least the first time. Now the follow-ups, they may not, and may leave you closed, but that first exam should be a nice, thorough exam where they're kind of going from the rooter to the tutor to see what all is going on there. Of course, we get vitals, which would be blood pressure, pulse, weight. Sometimes they get pulse ox as well. And, there may be some questions also about, there should be at least a few questions asked about your mental health, kind of depression screening and stuff of that nature, especially if you, depending on how you've answered some of the other issues that we covered already. Then we go to labs, and there are just tons of blood tests that are out there. But most of the time, most physicals, they're going to get at least a few things. And so they're going to check your glucose, just to screen for diabetes. Cholesterol is another screening one that most people will do if they have that. Complete blood count, this checks to see whether or not you may have something called anemia, which is the hemoglobin carries oxygen to the body. So a lot of times they will get one of those, especially if we haven't had any time soon. Basic metabolic panel checks for like your sodium levels, potassium levels. One of the big things it looks for is the creatinine level or GFR. So that's the kidney. That's the thing that tells how well your kidneys are functioning. So that's pretty huge. Sometimes they'll do urinalysis as well, especially if you have any sort of family history of kidney disease. And then others are kind of based off the answers you gave with the rest of that history and physical. So it just kind of depends. So like those kind of vary. Okay. Then imaging. So for most people that are otherwise healthy, you probably are not going to get any sort of imaging. But like imaging includes stuff like chest X-ray or CAT scan to kind of take a little deeper look into things. But like I said, that's, those are typically uncommon. But like I said, if you're a smoker or something of the nature, like I said, they may get, a screening CAT scan for lung cancer if you're an older person and you've been smoking for like, 30, 40 years. So they may get stuff of that nature, but it'll be based off the recommendations or based off of the, either family history or the history that you've given. Okay, cool. So this is kind of summarizing, my portion of this. Like I said, I know it was a, kind of a lot, but I also think that these are aspects that I have seen over and over again that people, kind of nuances that they may not know that I think are important in order to navigate the healthcare system. That primary care piece is really, I really think it's really important for us, because if you can get established with one, they can answer a lot of questions and they can really kind of help navigate that thing. And I know a lot of people feel like, well, I don't want all these man-made medicine, I want herbals and stuff of nature. You can find clinicians that are will accommodate. I mean, most clinicians won't care, but they're of course they'll be kind of dismissive. But then there are also primary care clinicians out there that will either they practice with herbal remedies or kind of non-Western medicines and stuff of that nature. But I do think it's important for you to go out and find one. And it's best to find one while you're healthy, because you want to establish that relationship. You want this to be it's kind of like getting a good lawyer. You want to find that person before you need them. And primary care is really one of those. So like I said, I really encourage people to kind of go out, find themselves a good clinician, and you may have to bounce around. It may, the first one you may be, I don't like this, or I don't like the front staff, stuff of the nature. Feel free to ask around, ask other people who've had good experiences, and go check them out, see how things are going, and kind of go from there. All right. So I think at this point in time, we can open up for questions. We can turn this over to Dommy, and we kind of go.
All right.
Cool.
Great presentation, Dr. Brown. We appreciate a lot of great information. We do have a couple questions. One from Brother Jeffries. It was with direct care, can an entrepreneur opt to not have insurance?
Yes. So you can, because some of these direct care people, most direct care practices do not accept insurance at all. So you can, so even if you have insurance, you'll get seen. They'll give you what you need to submit to your insurance company for reimbursement.
Okay.
But they, some of them do not, they don't, matter of fact, a lot of them don't accept insurance at all. They just like, it's everything is cash. I mean, they'll give you a list of, what their prices are. The other thing about some of these is that, they may have access to medicine. Some of them do wholesale for their medications, so they have lower costs for certain medications. So it's actually a really interesting way to practice medicine. And yeah, if you're an entrepreneur, honestly, you're right. For an entrepreneur, because what you could do is you can get try and find somebody that's got a plan that's got catastrophic coverage, so that if you wind up in the hospital, you get covered. But your basic care, just go find one of these direct care practices, and you got enhanced. You're talking about increased access to a healthcare physician or a clinician, at really, like I said, especially find one of these $40 a month plans.
Right.
I mean, that's like,
that helps,
exactly. Like, look, yeah. So I think that they're growing. I'd have to look around and see how many are like in the central Ohio region. But like I said, I know that they're that is something that is starting to starting to increase.
All right. We have another question from George Levy. He says, quick question. I have to take an annual biometric screening at my place of employment that provides me with detailed reports weeks later. Is that sufficient enough for an annual checkup?
It would depend upon what all is in this biometric. So like I said, I don't know exactly what what is included. Mm-hmm. So, because biometrics could cover a lot of different things. So the question is going to be this, and that is at your place of employment, is there a person that is willing to provide you with primary care? And that's probably the better question. Is this a primary, has your hospital or has your place of employment employed a primary care clinician to provide you with comprehensive primary care? That's probably the better question. Because if they've not, without knowing, what all elements are in this biometric screening, I don't know that I would just automatically assume that they're looking at all parts that need to be looked into.
Okay, great. All right. We have another question from M. Moulton from YouTube. What criteria do you recommend for choosing a PCP, primary care physician? Are there any medical advantages to choosing a Black PCP?
Oh, great questions. Great question. So I think in terms of criteria for choosing a primary care clinician, so there's something we participate in that's called board certification. And, a little controversial, but like I said, if if you have one that is board certified, that they have at least gone through this extra testing. Now, it's controversial as to whether or not that, what that really means in terms of practice, because I've known some very good primary care clinicians that now most of them I've known that are really good have at least gone through the board certification at least once. Now, they may not keep up with it later on, but they've gone through it at least once. So I would look for someone that has at least gone through board certification once. It's best, honestly, it's just best if they just kind of maintain it. It's a pain, but it does show you that person's willing to go through those extra steps and at least, answer these questions. So I would say look at board certification. Like I said, at the very minimum, that they have been through that process once, even if they decide, whether or not they decide to maintain it or not. And ultimately, like I said, if you can get somebody that's maintaining their board certification, I think that's probably the best. So that's in terms of training. So the other thing you want to look for is, who you feel comfortable talking to, who's able to pull those questions and ask those questions out of you. Because remember, this is very relationship oriented. There are some people I know of that, they'll go, they'll have their, and what they do, and this is interesting with with the primary care doctors and then the nurse practitioners or PAs, they'll go to the primary care doc, they'll get established, and then they may follow up with one of their nurse practitioners or PAs. Sometimes they just feel like, they like the comfort of having access to the doc, but they just talk better with a nurse practitioner or a physician assistant. So like for most of their routine stuff, they'll kind of go in and just talk with them. And then maybe if they have something they think is a little more serious, then they'll go establish with the primary doc. So that relationship though is very important because this should be something that should be ongoing. For a long period of time, that person is going to be helping you whenever you get, whenever you are at your lowest, whenever you're sick, whenever you had some major illness going on, and is also going to be referring you to different specialists based off of your needs. So I would say, look at the board certification, look at, how, the relationship that you all establish or that rapport that you have, because that's good. And I would say that those are probably the two best ones in terms of primary care physicians. Of course, the practice itself, it's always great if you have one that runs efficiently. And sometimes, so if you're having bad experiences in the front desk, I always tell people, like I said, if you're having bad experience in the front desk, but you like the doc, always let the doc know, or at least let the office manager know, because sometimes they may not know what's happening to you on that front end, and you don't want to lose a good doc or good practice because somebody that they hired had a bad day. So I would say that. Medical advantages to choosing a Black PCP. So I think that is something that is a little controversial. So I think that part of that goes back to that relationship issue. So if you have someone that is, if you're Black and you find somebody that's Black that come from their same kind of background, yet again, they know what to listen for. So I will use the example. So I've had, a Black guy come to me as a specialist. He's referred to me for hypertension issues. And that issue I was telling you about, the chest pain thing. So I talked to him and he tells me this story about, because he was a short order chef or whatever. And he said, yeah, he'd already told me everything was fine, whole 9 yards. And like somehow at the end, I can't even remember what we were talking about, something else. And somehow he's like, the only thing was that at my job, I just have to sit down because I just keep getting these, this little, it don't really hurt. It just feels weird. And I'm like, I don't know. You have any family history? And I, kind of go through that and find out basically he's got some risk factors for heart disease. And he's like, I think he's like 55, 57 years old. So I refer him to cardiology. Now he comes to see me a couple of weeks later for follow-up. And as part of my follow-up, I'm talking to him about, kind of go back on the issue of like, hey, how was the cardiology visit? He's like, I didn't go. Why? Why? He's like, yeah, well, I felt fine. Like I said, every time I sit down, I'm good. Like, this thing goes away. And then that's where I had to, because I have family that ignores health issues, and because I've seen this, what happens when they don't, I take that extra time to explain to him, like, no, like I said, the symptoms that you're describing are the symptoms of a heart attack. So you had to break it down to like, look, this, no, bro, no.
Yeah.
That's what happened with, this is what happened with Aaron.
You can't skip to the point.
Exactly. I had to, keep it a little more real. And so you can get those sorts of experiences there. So like, you're more than likely going to get them with a Black one. Now I have had, I've had visits with white folks that do it, but like I said, it's a little less common, quite honestly, because usually it's a little more passive aggressive and stuff of the nature. But sometimes you have to just, honestly, you just have to have a real conversation with them and say, no. You have risk factors you could have a heart attack. You could have a heart attack right now. And like I said, then he went and, he went and got evaluated, got some stents before his heart attack. But I mean, sometimes I think that those are some of the medical advantages. And there are, I mean, like I said, there's data out there that says that, having a, especially for, and I think especially for Black folks, you know, because we have to remember, I mean, we're in an environment where, other folks, white folks or whatever, sometimes don't even realize, at least I'm convinced, I don't even think they realize, what's going on,
Right.
with us. And so I don't even think it's like I've had some people say they think it's intentional. I don't think it's intentional. I think it's just, there's the cultural differences are just that big. So like for us, we are in both our world and their world. But for them, unless they've had a good friend or somebody around their family, like, we're in a totally, we might be in a different country. And it's not always unintended. It's not like it's intentional or something nature, but it's just really just, the way our society trains them to interact with us is remarkably different. And it's interesting to watch. And so I think that those things can lead to, not addressing issues that are urgent. So I think that that's where, making sure you have somebody, and that's where making sure you have somebody that you feel comfortable with becomes important. And of course, for Black folks, like I said, a lot of times that comfort level is going to come with folks within your culture. So,
yeah. And the other part of that is, in general, men, just speaking on the term in the terms of men, we have problems asking other people for help anyway.
Mm-hmm. Yeah.
So you layer on gender on top of culture. So we're already, that those chronic stress conditions, we already just kind of want to self-diagnose. And then as men, we have a hard time admitting that we need help, asking for help. And we find that as a sign of weakness if I've got something wrong or if I've got to go in and get help. So that on top of all those things that you've talked about, make it really important for us to put our ego aside and get checked out.
Exactly.
Right.
That example, like I said, he was not, I mean, like I said, honestly, he skipped that until he'd had a heart attack within a year. There's no doubt in my mind. But
a lot of it, we have to get over that I'm good attitude. I'm good. I got it. I'm good.
Well, I think that kind of like Marcus was saying, is that, we are conditioned,
right?
To, there's the myth of being independent and strong in America, and it truly is a myth, that that we're fed, and that is that we can work through it, we'll make it work the whole 9 yards, which is quite ironic, being that kind of as men, because I did this talk for a church one time, because like as men, we're taught as independent, strong, we ain't got to admit our weakness. But if you think about, what images come to mind with masculinity, soldiers, CEOs, things of nature. Well, soldiers get an exam before they go in. They get regular exams. CEOs,
they get shot. They get all.
They get shots, the whole 9 yards. They get all that stuff. They got free access to care. You can go get your medic all the time. Right. CEOs, which I think are also kind of a traditionally masculine sort of role that we think about. But CEO, you can go get an executive physical. An executive physical goes beyond any physical that you're going to get in anybody's primary care doc. Say they're going to go through the root of the tutor. They're going to stress your heart, the whole 9 yards, just preemptively. So, and then, like I said, especially for the majority culture, white culture, they're always, they're always in their doctor's offices, getting things taken care of. If there's a little mass here, they get stuff cut off. But for us, we're kind of told, or we've kind of got that culture in there that no, we just need to rub some tussin on it and keep moving. It's interesting. It's as you get out, but at some point in time, you realize it's part of the conditioning of us
Right.
To make honestly, well, really, it's to make us weak. Because once your health goes, you can't do your manly duties,
Right.
providing and protecting.
Right.
So, so it's going good.
And I know we've got some other questions coming in. If I could request some of these COVID ones, I want to make sure I know that we acknowledge those. But Dr. Brown, that probably would be something we'll acknowledge at the very end, because I know that's going to be a whole can of worms. And I don't have much, but I want to make sure we save that COVID stuff.
Okay.
And we'll do that Q&A at the end. I see these questions coming in. I want to make sure that we acknowledge those, and we'll definitely get to those.
So Dr. Brown, from Shay Okote, he's asking, what's your opinion on high blood pressure medication? And is there a natural approach to lowering blood pressure counts?
Okay. So in general, the way I approach high blood pressure is I always advise people to do lifestyle modifications. And I think Mark is going to talk, kind of talk on some of that a little later on here. So lifestyle modifications always first. However, that depends. Like I said, if your blood pressure is say your blood pressure is like 150/90. Yes, you got time to do lifestyle modifications and de-stressing stuff of that nature. Now, if you come to me and your blood pressure is, yet again, 210/105, I'm gonna give you some meds. Look, you can still do the lifestyle stuff, but there's a certain at some level of blood pressure. I'm concerned about what could happen between the time you leave my practice and the time you come back. And so I'm probably going to start you on some medications. So blood pressure medications are extremely important. And also remember that you can still do the lifestyle modifications even on the blood pressure medications. And what you do is that as the lifestyle stuff works, then you can back off the meds. I've had people that have done that. They lose the weight. They don't need blood pressure medications. And so we can cut them down. Every now and then I can get them off. Most people will require at least one, but like I said, sometimes they may go from 4 medications down to 2. So I mean that's huge progress. So yeah.
Okay. Is there anything natural that you can think of, like I don't know, a fruit or something that they can start taking that might help out, or something that way?
So okay, so I'm trained in Western medicine. So trained in Western medicine. So what I'm looking at are the FDA approved medications. So there's not a natural medication that's approved through the FDA. There are plenty of other things. There are plenty of things that people say use it. I mean, I've had people that do the apple cider vinegar and stuff of that nature. I don't tell them not to. You can always try it. For the most part, I can't think of anything off the top of my head that's necessarily harmful. I just don't have any evidence that it actually works. So if you say, hey, I want to do some apple cider vinegar daily, knock yourself out, but I got some Norvasc too. So that's the way we approach it. But the natural thing is, and again, that'll be going back to Marcus. It's like, the exercise diet.
Yeah.
That's natural. Less is more.
Yeah. And I know one thing, it's not necessarily a thing that you take in, but I know one of the contributing factors to high blood pressure is hyperinsulinemia. So when you've constantly got insulin running through your blood, and diabetics are a lot of times deal with high blood pressure because you're always pumping insulin through your blood, which is a result of either always eating high sugary foods and low fiber foods and all those kinds of things, and breakfast at 7 a.m. and you eat all day until you go to bed. So your body never experiences a prolonged period where it's not insulated in your blood. So you've got blood plus insulin. So if you think about it, a tube with just blood and then you add in something else to it, I mean, you're just clogging up or not clogging, but you're just adding more volume to what your veins have to manage and deal with. So that's another thing that, going back to the lifestyle, a lot of things that you hear about, it's not necessarily what you need to add. Most of the time, it's something that you need to take away. So we need to start looking at not just what do I need to add, what do I need to do, what do you need to stop doing and stop adding and back away from. That will actually help in a lot of your situations.
Exactly. I'd agree with that.
All right, we got one more question before we get to Marcus Bailey and his great presentation. And you have any thoughts on prostate exam prior to 50 years old? A lot of doctors won't recommend a prostate exam until then. Are there any issues with insurance paying for a prostate exam before then? This is from William. This is from Ryan Williams from on YouTube.
Yeah, actually, for African Americans, we're supposed to start at 40. So, and the prostate exam, there's something called a digital rectal exam. Then there's also something called PSA, prostate specific antigen. And really, we should be getting that at the age of 40. The insurance coverage, it should be covered. But I always tell people, you know, check with your insurance company. And if they're not covered, ask them why. Because you can definitely pull up data that says it should be, you should get that screening at that age. And one of the reasons is this, and that is, you know, the DRE or the digital rectal exam is, you know, like I said, that's one part of it. But the PSA, the prostate specific antigen, once you get that what we call that baseline level, you know, part of it will be to determine if this is rising or falling. Because what can happen is that, say that you didn't get it at 40, but you got it at 50. And it's just slightly elevated. Well, if it was slightly, so say that you went back to 40, and if you would have had it there, it would have been the same. That's one thing. But if it would have been much lower and all of a sudden it's high, that's a totally different thing. So that's one of the reasons for getting that baseline PSA.
Great. All right, we got a lot more questions, and let everybody know we are going to have a full Q&A session covering everything at the end of this, at the end of the panel. But I definitely want to thank Dr. Brown for his expertise and his guidance in this health issues that we have, and a lot of great information. But what we're going to do now, we're going to switch a little bit, and we're going to go to Marcus Bailey. Like I said before, Marcus is a great resource on lifestyle modification. A lot of this, like he was saying, a few minutes ago, a lot of it is taking something away. You don't know what you're doing. You know, sometimes you like I said earlier. I don't know if everybody was here, but you change out that donut for an apple. You know, it's a simple thing that you can do in this lifestyle modification. And that being said, I'm going to let Marcus Bailey go ahead and do his thing.
Okay.
Thank you.
Appreciate it. And first of all, I appreciate you, Dr. Brown, for sharing your wisdom and bringing that primary care side. I mean, I couldn't agree more. We all need, even though I'm going to talk about what we can do individually, it's just so valuable to go see a professional, an expert. So expert advice in all things. And I see, Perry dropped a comment talking about the executive physicals.
Right.
We're the heads of our households. We're the executives of our homes. So it's just as important for us, as he said, to make sure that we're okay. And he's someone, and a lot of the people who are in these comments and on the chat, and you as well, you all are professionals and experts that we as a community need to lean on, and we as men need to make sure that we leverage our resources and go to experts when we need. So with that said, I'm going to talk about lifestyle modification. Lifestyle modification, I'll start with a definition. Really what that means is that involves altering habits, which typically include nutrition, physical activity, and maintaining those new behaviors long-term. The lifestyle modifications can be used to prevent and treat a range of health conditions, including obesity. So a couple of key words here that I just want to make sure that I preface the rest of this with, so that everyone has in mind, is altering habits for long-term results. So what we're talking about here is not doing a quick fad diet or a 30-day challenge. Those are okay. That's a whole nother thing and for a whole nother reason. We're talking about truly changing your lifestyle for long-term results. So let me introduce myself. First of all, again, my name is Marcus Bailey. My passion is turning my own personal 15-year health journey and education path into practical and straightforward information for others. As a disclaimer, as Dr. Brown said, this is for information and education purposes only. So I certainly would defer when someone has an acute scenario or an acute symptom to go to a primary care physician. My goal really is to help as many people as possible make the decision to take control of their health and wellness. And the key being, make a decision to take control. And we'll talk more about that. So ultimately, my approach is to make things simple and relatable so that the health journey that you take is more enjoyable and easier to stick to long term. It feels like something that's manageable. You understand it. It makes sense. You can relate it to other areas of your life, which I'll use several examples as we go through. So what we're going to talk about is we will start with what we believe now, kind of our current set of beliefs and just a few of the paradigms that we operate within right now when it comes to health. We'll maybe look at a couple of things differently and maybe put a different spin on something that you may have taken for granted or something that you've just kind of done subconsciously in terms of diet and in terms of nutrition and exercise. Also, we'll talk about a couple of things that you can do now, easy things that you can do today in the spirit of that, taking something away or adding something easy to really start you down that path. Because ultimately, like the book, The Compound Effect, better health, better life, success in any aspect of your life isn't about doing a complete 180. It's about stacking habits on top of each other, doing one thing that leads to two, that leads to four. You look back a year or two and you're far, far ahead of what you thought you could be. And then the last thing, I want to give a couple of things. I want to be very honest and transparent about some things that you can expect as you get started. So let's talk about what we believe now. Some of this is cultural, some of this is societal, but you've got this battle between the fork and the family. So the fork being, and that kind of represents the level of personal responsibility that we take, how much impact we believe we can have on our own health and wellness. Now that's to a varying degree. Some people believe you can have a lot of impact. Some people believe, hey, you know what it is. My family has this, therefore I'm destined, I'm guaranteed, I'm doomed. And that's the other side of it. The degree to which we believe family health history, genetics, and heredity plan our health. And this isn't for all scenarios, but this next slide is going to go based off of a recent study done by the National Institute of Health. They gave a breakdown of health determinants. And these health determinants simply say, what percentage in general do these things play on your health outcomes? So the first thing is medical care and services. So obviously, access to a primary care physician, being able to speak to someone like Dr. Brown and have access to the insurance and the means to access those services are important. So that's 10 to 20%. Genetics, that plays a part. You may have some genetic predisposition of some things. Certainly, it is a factor, but far less than what maybe a lot of us thought. So 20%. Another thing is socioeconomic. So an individual's position can be, shaped by things like education, occupation, income. So that plays a part because you just might be in a scenario like you're in a food desert. You may grow up on a side of town where there is very little access to fresh food and fresh produce and all those different kinds of things. So the next thing is physical environment. We certainly deal with that: outdoor air pollution, household pollution, drinking water, occupational exposure. Dr. Brown talked about, asbestos. That's not something that we necessarily have to deal with much now, but there still are occupational hazards. But I want to really focus on behavior and lifestyle. So as you can see, individual behaviors such as substance abuse, diet, and physical activity play a major role. That's 50 to 60%. Something I'd like to point out, let's just say socioeconomic conditions aren't really a factor for you. You may live in a good place. You may have insurance. You may have the education and the occupation that facilitates good health. Where does that percentage go? So if that 10 or 20% doesn't affect you, or if your physical environment does not affect you, where do those percentages go? You can't put more into genetics. So as soon as you start making more money, your genetics don't kick in and say, hey, well, since you've got insurance, I guess I need to come up with some worse conditions. So that's where that all needs to go in the lifestyle. You have the opportunity to really stack the deck in your favor. How much of it can you control? So let me give a couple of statistics here. The leading causes of death worldwide are chronic diseases, things like cancer, cardiovascular disease, COPD, diabetes, stroke. About 80% of chronic diseases are driven by lifestyle and factors such as diet and exercise. And that's from the Cleveland Clinic. So my point here is don't focus on the 20%. You've got 80% control over what happens and over your health outcomes. So don't focus on the 20%. We have a lot of say in terms of what happens to us. So the next thing is what we believe now, or in that spirit, is age equals condition. So we've got kind of a thought that the passage of time determines biological aging. So if that's true, then why is it possible for some people to look good for their age? If it's not true, then why do we give so much credit to age when we experience certain conditions? So I'm 40 plus, I'm 43. So I've got people who, and you all know people who at 40, 30, 40, 50 will say, hey, you know what? I just hit that age, things start hurting. I'm at that age where X. And we just automatically attribute it to age because we just think as soon as you hit a certain point, things just have to break down and things just have to go wrong. I want to give an example here with type 2 diabetes. And this is information from the American Diabetes Association. And I'm not going to go through in great medical detail, but I just want to point something out. First of all, type 2 diabetes used to be known as adult onset diabetes. Keyword being onset, meaning it comes about. It doesn't, you don't walk outside, someone sneeze on you and say, look, hey, keep that diabetes to yourself. You don't, there's no public health, thing saying, hey, wash your hands or else you're going to catch diabetes or anything like that. Diabetes is something that progresses. And these are the 5 stages, according to the American Diabetes Association. Excuse me, I'll start at the left, where when you look at compensation, that's really the stage where, based on the fact that we are over insulinated or hyperinsulinemia, as we talked about, during Dr. Brown's Q&A, we just are always eating things that are sugary, things that create an insulin response, things that create an exaggerated insulin response, down to the point where your body says, hey, listen, I see you're going to be eating this stuff all the time, so I'm going to start sending out twice as much. I know that I'm going to need a lot, so I just kind of get used to sending out more than what I need. Then you get to the point where you start getting into that insulin resistance piece, where even though your pancreas is sending out the hormone, your body's like, look, I'm not responding like I used to. So now you get into this back and forth where you're shooting out more insulin and your body's not responding to it as well. All the way over to the point where when you get really to the severe decompensation phase, that's where you got people who are insulin dependent. They absolutely cannot manage their diabetes without getting insulin shots. Now, a lot of times people just have to kind of watch what they eat, maybe at that stage 4 where they're just checking their insulin and all those different kinds of things and watching their diet. But my point is, this is a progression, and anything that's a progression means this happens over time. So it doesn't happen at the same rate for everyone. But what we may think diabetes is, hey, it runs in my family. The fact is the habits run in your family potentially. And your dad got it, your granddad got it, your aunt got it, your mom got it. They all got it about the age of 35 or 40. And you may too, because you all have done the same thing for the first 30, 40 years of your life. You've eaten the same thing for the first 30, 40 years of your life. So it takes that same amount of time for your body to say, hey, look, time is up. I've had it. I'm moving through these 5 stages. And now all of a sudden, here we are. So I wanted to point that out, that things like type 2 diabetes is a progression. So something else that we believe is what's done is done, and that just kind of talks about we're just stuck with the conditions that we have. Um, you know, it's hard, if not impossible, to lose weight once you hit a certain age. I hear that a lot. Hey, I'm a certain age, man, this weight just won't come off. It's just hard, if not impossible, to lose weight or to do this once you hit a certain age. And people will talk to young folks, hey, man, don't get fat like me, because once you hit my age, you'll never be able to lose it. So we kind of have this thought that once you hit a certain point, you're stuck, you're frozen in time, and you're just doomed to suffer from whatever it is that you have. Let me flip away from health real quick. Let me give a financial and career success example. Stan Lee, Marvel, we all love the Marvel universe. He created his first comic at the age of 39, or just shy of his 39th birthday. Samuel L. Jackson, he had a few small parts, but he really didn't get his big break until 43 in Spike Lee's Jungle Fever. Sam Walton, Walmart, we all know about that. I think it's I know it's the wealthiest family in the world, because all the Waltons are on the Forbes list. But he opened his first true Walmart at the age of 44. So then the other thing is, let's look at you. Let's look at other aspects of your life. Every one of you watching has done something that you've overcome something, you've reversed a situation, you've changed a circumstance, you've made some improvement. And you didn't do it in your 20s. You did it in your 30s, you did it in your 40s, 50s, 60s. Whatever age you are, you were able to overcome something and take a different direction. You've changed a career, you doubled your pay, you started a business that you wanted to start. And I'm sure other people told you you're too old, it's too late, don't worry about it, you're just stuck. No other aspect of our life do we get to a point, and this next slide will address that. We believe and we tell our children that we have the power to change and improve every aspect of our life. Money, hey, if you want to make more money, just start doing the right things. You can reverse your financial circumstances by doing a few things. Spirituality, hey, we talk about starting to go to church, or you can repent, you can get baptized, you can get changed and save your life, and confess, and all those different kinds of things. With relationships, hey, if there's someone that you haven't talked to, that you're not in agreement with, talk to that person, change that relationship. Career-wise, you can change that. Parenting, if you like a better relationship or to improve your parenting, do that. Why is it with health that we just kind of throw our hands up and throw in the towel and give up our power with wellness? So again, relating that to other aspects of life, a lifestyle modification is possible in health, just like it is in every other aspect of your life. So let me go out to, let me throw a few things when it really comes to lifestyle modification and how we need to think differently about some of the things that we probably have taken for granted, or maybe we heard about, or things that we think it's okay, moderation is good, a little bit won't hurt. Let's talk about sugar. They don't care about us. And when I say they, I mean the food industry. In some part, the regulators who are allowing all, the labeling, and the FDA and the USDA and all these kind of organizations, these folks aren't making decisions based on our health. They're making decisions based off of their financial bottom line. So let me give you a few facts about sugar that hopefully helps. It's used, and we talked a little bit about that with Dr. Brown as well in some of his Q&A. It's used to replace flavor when fat was removed. So all these processed foods that you see, which we'll talk about next, they pull the fat out and they've got to add sugar so it doesn't taste like cardboard. It's used to cover up salt or bitter taste. So they add salt to, soda, and they put sugar in to cover the salt. They add salt to bread. They add sugar to cover up the bitterness of the salt. So here's two things that I want you to know. One, it's bad. Added sugar is bad. And let me be very specific. I'm talking about added sugar. So sugar that has been added in addition to what as it grows or as it comes naturally. Added sugar is bad. And two, it's addictive. So there's two things that make sugar addictive, or two things that make anything addictive, and that's tolerance and withdrawal. So when you eat a lot of sugar, or when you eat sugar, eat sugar, period, you get a dopamine response. So that's where that emotional eating comes in, where people, you sit down, you're having a bad day, and you open up a tub of ice cream, or, you see on the movies, they're popping the chocolates and all that kind of stuff to make themselves feel better because they get a dopamine response. Well, over time, the reward centers of your brain say, hey, listen, that's enough. I'm going to down regulate this. And now it takes, instead of 2 cookies, it takes 4 for you to get that same level of happiness. Instead of, a bowl of ice creams, it takes a bucket, to get that same response. So you build a tolerance just like you would a drug. Then you get withdrawal when you try to eliminate it. So consuming it creates a problem, just like eliminating it will take you through a period of withdrawal. We don't really ascribe addiction to sugar because we just think of the hard stuff, the drugs, all those kinds of things. But sugar is just like that. So a few stats: 74% of packaged foods have sugar. So if it's not in the produce section, 75% of everything else in the grocery store when you go this weekend is going to have added sugar in it. On average, about 100 years ago, each person in this country consumed about 2 pounds of sugar per year. Now we consume about 152 pounds per sugar each year. That's because it's hidden in everything. And again, we think in moderation is okay. And, we just add a little bit here and there, and that adds up. No one's perfect. I'm not saying anyone should go out today or tomorrow and say, if you have 1, grain of sugar, you can forget about it. The goal is to be conscious about it. And there's 50 plus names for added sugar. You may know it as, cane sugar, organic cane sugar, or high fructose corn syrup, or dextrose, or maltodextrose. It has all kinds of different names. And if you read the label, you'll see all these different things. And it basically is 10 different ways to put sugar in it. But they want you to see it and say, oh, okay, it's got all these other things, but it's only got a little bit of sugar. So again, we call it a craving or a sweet tooth, but ultimately for most of us, it's an addiction. And when you start thinking about it that way, then you start thinking differently about how you approach it. And I'll just give you another example. If you really saw sugar as a bad and addictive property and a bad and addictive substance, you treat it that way. If you knew someone who was addicted to heroin or crack, you wouldn't say, hey, look, man, just in moderation, man, just take 1 hit a week, treat yourself, hit that pipe once just to make yourself feel better after a bad day. Those aren't things that you would try to plan on. You wouldn't advise someone to do it. However, if it happens, hey, look, let's get you some help. I slipped up. I'm back on the straight and narrow. That's okay. That's not something that you want to plan on doing or use as a reward or think of in your mind as something that's beneficial for you to wind down. So the next thing is processed food. Really quick, fast doesn't mean convenient. Easy doesn't mean good. So fast and packaged foods are really made available for you to grab and eat on the go, maybe quickly prepare at home. But in order to do that, they've got to be stripped of a lot of the nutritional value and almost all the fiber so that they last in your cabinet and on the shelf in the store. Food that is easy to get may also be easy to overconsume. So the ease of access is really not for your benefit. It's really to increase the sales and revenue potential of the food companies. So processed food is another one of those things that you should look to modify your lifestyle and your behavior and your eating habits to move away from and move into real food, things that come from the farm, or if you're going to eat meat, eat it from a farmed and butchered, source versus a processed form, like you see the hot dogs here and those types of things. So let me just give you a couple of examples that we already know how to do this. This already makes sense to us. Stealing is a fast and easy way to get money, but we don't necessarily advise it because there's consequences that come with it. Jumping off a cliff is a fast and easy way to get to the bottom, but it comes with consequences. Lying is a fast and easy way to get someone off your back, but we know that comes with consequences. The relationship suffers. Quitting your job is a fast and easy way to get some time off. If you're tired, or if you just want more time at home, just quit your job. You'll have all the time at home that you need for as long as you can keep your home. But we know that everything like that has consequences. Let me relate it back to children. We tell our children anything worth having is worth working for. I'm only just trying to get you to understand that things that are convenient and fast in all other aspects of our life are typically we're a little bit suspect of. Too good to be true. This sounds a little suspect to me. But when it comes to fast food and easy food and processed food, we just say, oh, how convenient. This is easy. They put it all in one box. You throw it in the microwave for 2 minutes and you got a full Thanksgiving dinner. God bless the food companies for making it so fast and easy for us. So use that same skepticism when it comes to your nutrition, your diet, and the things that you take into your body, because there are also consequences with that. The only difference is your body's controlled by natural law. So you can't control those consequences. You can't fool your body into doing things a certain way or processing or digesting food a certain way according to what you want. So the last thing I'd like to point out when it comes to thinking differently is dairy. This is an example of when marketing messages become law, they become fact. So if you think about the adage, milk does a body good. Well, whose body and what good? So in 2019, there was $7.43 billion US spent on advertising just for dairy. Not because they really wanted, that wasn't $7.4 billion spent because they really care about you. They really care about me. They really care about our health. And they really are so concerned about the welfare and the longevity of every single person that drinks it. It's an opportunity to sell milk. So let me talk about a couple of things that we typically think milk is good for. First of all, it's calcium. We always think, hey, milk is for calcium. Well, let me just give you an illustration here or just kind of point back to the source. Calcium is a mineral found in soil. It's absorbed into the roots of the plants. Cows get their calcium by eating these plants. You get the excess calcium they give off. So milk doesn't have calcium as an original source. You're getting pre-digested and excreted calcium that's left over from what the cow didn't want. So there's plenty of calcium, very calcium-rich sources outside of drinking milk. Something else that I'd like to point out from the Arthritis Foundation, I know a lot of men, particularly when you get, if you've played sports when you're older and as you get, or younger, and once you get older and we start to get things like gout and arthritis and all these pains and joints that set in, One of the things that we don't realize is a diet high in saturated fats, which includes dairy. There's a lot of inflammatory properties of dairy as well, but particularly things like, heavy milks, cheeses, and creams. Those are really big inflammatory items. That's from the Arthritis Foundation. So back to the question I think that the gentleman asked when we talk about what things can you take for this, instead of taking something for your arthritic conditions, another opportunity might be to modify your lifestyle so that you can then reduce the effects or the pains that you even have from it. So if I can stop the symptoms from arriving, I don't have to take any medicine to fix the symptom. A couple of other points that I'll throw out: estrogen. So I don't know if you all were aware, but I think it's very important that people know that, commercial milk is produced from cows that are being milked long into their pregnancy. And a pregnant cow produces a lot of estrogen. So you're getting a lot of estrogen in your body just by taking in milk. Estrogen, if you didn't know, is something that both men and women produce, but both men and women have a different balance of how much testosterone and how much estrogen you should have. So once you become estrogen dominant, the body says, well, let me slow down my production of testosterone. So one of the things that I hear is, hey, once you hit a certain age, your body stops producing testosterone. Is that because you hit a certain age, or is that because you've created an estrogen dominant environment within your body? We don't realize that we're taking in a lot of extra estrogen just by taking in dairy. Not because it was added in or anything like that, but just simply because the cow is giving milk while it's pregnant, it's producing estrogen, you're drinking estrogen. Gynecomastia, man boobs, that's another thing that is typically, excess breast tissue. So a lot of the conditions that we think are just happening because of something else is happening because of what we're doing. I'll talk about prostate. A study showed that men who consume 3 or more servings of dairy products per day had 141% higher risk for death due to prostate cancer, not just instances of, but death due to. Milk also contains a lot of things like IGF-1s, insulin like growth factor 1. It's, again, inflammatory. It's also estrogenic. So when you look at the prostate, particularly for men, milk is not something that is favorable for good prostate health. And that actually came from the American Cancer Society. So the last things I'll talk about, and we'll get to some Q&A. I know there's some other things in there that you all want to hear from Dr. Brown, and I'm certainly open to any questions that you have on anything general. What can you do now, today? First thing you can do is track everything you eat. The best way to make an adjustment to any lifestyle, behavior, or habit is to first be crystal clear about what it is you currently do. So again, I'll relate this to any other aspect of your life. If you're looking to have more money saved at the end of this year or 2021, you're going to have to take a look at every dime, every nickel that you've got coming in, and you got to track where that money is being spent. You can't spend, unconsciously and then consciously save. Same thing with, at work. If you want to be more productive, you've got to be more cautious of your time. You're going to track your time, a to-do list, a calendar, whatever the case might be. You've got to protect the time and the limited resources that you have and know exactly where every minute is going, where every dollar is going. With diet, you've got to know where every calorie is coming in. Just by tracking that, it'll open your eyes. It'd be unbelievable once you start looking at exactly what you eat. You'll be surprised about how many calories you're taking in, how much sugar. Once you start reading labels or scanning it with the phone app like MyFitnessPal or something like that. Once you start paying attention to those things and not just mindlessly snacking, you'll be very, very surprised on how much improvement you can make just by doing that. The next thing is eliminate one thing at a time. So I'm a very big advocate of, as I mentioned before, the compound effect, habit stacking. It's great if you say, I'm going cold turkey, January 1st, New Year's resolution, new year, new me. I'm going in the kitchen, I'm throwing everything out of my refrigerator, and I'm buying all healthy stuff. If you can do that, that's fantastic. If you can stick with it, that's even better. And I wish you the best. Most people are going to do much better and stick to it much longer if you just get in the habit of eliminating one thing at a time, for two reasons. One, you might already be eating some stuff that's good. So if you eat a lot of vegetables, but you also drink a lot of pop, keep eating the vegetables, just start slowly getting rid of the pop. If you drink it 7 days a week, maybe go down to just the weekends. If on the weekends you drink it 3 times a day, just maybe once. And then all of a sudden you've gotten rid of that. Now you can look at something else. A month down the road, you've eliminated pop, you're still eating your vegetables, and you can look at anything else in your diet that you may need to get rid of. So one thing at a time, you will find that your body will get used to it. You'll get to the point where you no longer crave those items. Your body no longer needs those items. You actually may get to the point in a lot of things where if you were to reintroduce those items back into your diet, like pop or processed foods or fast food and all those different kinds of things, you don't like it anymore. You actually say, hey, I don't like fried chicken or fried this or whatever that. I need baked. I need to make chicken at home. I need to make it myself. I need to get organic this or whatever the case might be. So the last thing, join the resistance. No gym, no problem. I know we're in a unique situation with COVID. Some gyms are closed. People may be uncomfortable going. You may not want to get a gym membership. You may not want to go through that whole rigmarole of building a home gym. That's okay. At the very least, men, we need to understand that muscle strength is critical. It's not just for looks. In fact, it's less for looks than it is for health. We don't realize how important strong muscles are to our overall health. If you have a weak back, you have poor posture. If you have weak muscles, then it's really hard really to hold your frame up. There's a lot of muscles that go into a lot of the different functions that we don't realize. Muscle is a good fat burner. So if you're looking at weight management, muscle burns a lot more fat or a lot more calories rather than any other organ in your body. Muscles are just calorie hogs. So that's the other thing. Resistance bands are a great way to strengthen and build muscle. There's a lot of great exercises you can do with resistance bands, but you have to get your body used to moving something, doing something, performing some movement that's heavier than what it's used to. So if you weigh 200 pounds and you do something where you're doing resistance bands, where you're doing maybe some squats that are 50 and you're doing what would be the equivalent of a 250-pound squat or exercise, your body needs to get used to doing more than what it has to do on a regular basis. And again, to relate that to regular life or to real life, that's what we talk about all the time anyway. You got to stretch yourself. You got to practice better and do more, practice with more than what you actually do or what you actually have to deal with on a daily basis. To close out, I'm going to give you 2 things that are very honest, very transparent, and I'll be very clear about what you can expect. The first part is you might be alone. You might be the only one in your house or circle of friends to take it seriously. Do it anyway. Lead by example. If you're waiting on someone else to do something first before you do it, are you going to, you're going to be waiting for a long time. Is there any other aspect of your life where you wait for someone else to do it? When you walk into your job, do you say, hey, I'm not going to start doing a good job until Tim, Jerry, and Joe start doing a good job? Other than that, I'm going to sit here and I'm going to risk my job and my livelihood until I see someone else do it. Do it for yourself. Don't wait on someone else around you. It's a solo sport. It's your health, by the way. You're the only one who can benefit from you being good. Whatever you eat, that only benefits you. In terms of digestion and all that kind of stuff. You might be alone. Lead by example. Look better, feel better, speak better, and other people will follow you from there. The other part is it might be hard. Bad habits are hard to gain, but guess what? They're also hard to get. I talked about before in another video that I had or an interview where, no one picks up that first cigarette and smokes it and just thinks it's easy and smooth. You cough, and it takes a while to get used to a bad habit. A lot of us, when we grew up, our parents, our dads, gave us a beer at 7 years old and it was nasty. We may have thrown up. Now you might like it now, but when you first started, you didn't. So it's hard to get a bad habit, and it's also hard to break one. So it will be hard. Be patient with yourself. I'm just being honest. It's not an easy thing to do. It's simple, but it's not easy. So with that, I appreciate your time. I've got my YouTube channel here. I do have some other things coming out down the road, in terms of a book and a website and all those kinds of things. But right now, my really main goal, again, is to help as many people as possible take control of their health and wellness. You can visit that YouTube channel, Marcus Bailey Health. I've got content that's posted on a regular basis that hopefully is helpful. I make it relatable. I make it real. It's not always the information you may want, but hopefully it's what you need to inspire you to do a little something to feel better, to look better, and add some years to your life or quality of life to the years you have left. So with that, I will unshare my screen and we'll go back out to Q&A.
All right. Thank you, Marcus, man. We appreciate that, man. Great information. One of the biggest things Marcus is talking about, you got to make the switch. It starts with you. Everybody knows me, or a lot of people know me, and my motto is be the example, not an example. You can't wait on somebody else to do it. You can't. You have to start. Sometimes you will be on that island. You will be the only one speaking your truth. But believe me, with my testimony, once I started doing it, I found out there's a lot of people who wake up every morning to see what I'm going to post.
Yeah.
See what I'm going to, if I did my multivitamin, to see if Dommy can do it, you know what? I guess I can do it too.
Yeah.
We lead by example.
And here's the odd part. In one instance, just before on Dr. Brown's part, when we were talking about Q&A, the one part that we all acknowledged is we're too proud. We have a big ego. We stick our chest out and we get very self-assured and independent when it comes to asking for help.
Right.
I don't need anyone to tell me what to do. And we get real confident there. But then as soon as it comes, we're talking about this stuff, oftentimes we actually do the exact opposite and we cower away until we see other people, So it's just really important for me to let people know everything you need to be successful with your health and your wellness. You already possess those qualities. You already know how to be selfish. You already know how to do something on your own, for yourself, by yourself, whether anyone else likes it, supports it, endorses it, or cares about it. We already know how to do that. We know how to slam the door, walk out and say, I don't care, I'm doing it, and I dare you to say something about it. We already have that skill, that quality. We just need to apply it in this context and not care about what other people say, not care about what other people think. Because at the end of the day, and at the end of our life, we're not going to be able to say, damn it. Why did I let someone, at that point, you've given up too much for the sake of someone else's opinion,
Right.
So, we already possess the skills necessary, which is, again, my most important message is you already have everything you need. So that's a good point.
Right. Yeah. And make sure y'all, like Marcus was saying, go check out his videos on YouTube. Follow him on social media. He has great information. A lot of eye opening things with his vlogs, and he'll tell you as soon as they come out, I'm probably the first one to like and share because I'm on it. But and that's not just because he's my brother in Kappa Alpha Psi, it's because he's giving out great information that we just need we need it. Sometimes the easiest thing you can do to improve somebody's life is clicking that like button and sharing it.
Mm-hmm.
You never know who you're going to touch and who needs that information, because like we keep saying, we're prideful. We think we can do it ourselves. We think we're the only one going down this road.
Mm-hmm.
And when we found out that there's brothers like Dr. Brown, Marcus, and everybody else who's on this YouTube and on Facebook with us and joining in, when you find out there's somebody that's going through the same thing as you, it that weight on your shoulders, it's like, wow, you too?
Yeah.
Let's. So there's some questions from I guess it came from YouTube. They're asking, is milk okay in moderation, or should you completely remove it from your diet?
Personally, I would suggest that you remove it completely from your diet.
Okay.
And I'm going to give a few reasons why.
Okay.
One is because anything that you have to, I think you should just question anything that you have to put an asterisk of moderation. You should question why you're doing it in the first place. Now, again, whether you choose to do it or not, that's up to you. I would advise that you get rid of it completely, because there's really nothing else. No one tells me, hey, look, slow down on the broccoli, bro. Moderation, easy. No one tells me, hey, look, man, slow down on drinking enough water, easy. But it's only the bad things that we put a moderation on. And I'm just going to be really honest here. Moderation, in my opinion, is just an excuse or giving ourselves permission to do something and think of something that really is bad and just make ourselves feel good about doing it anyway. Now, let me say that with a disclaimer. No one's perfect. So I'm not saying if you do it, shame on you. What I'm saying is don't plan on eating it. You know what? I'm going to eat ice cream in moderation. Hey, look, don't plan on eating it at all. But if you find yourself at a birthday party with cake and ice cream, oh, shit. Well, okay, I had it. Great. Moving on. I'm not planning on doing it. There's nothing from milk that you can't get anywhere else. It causes more problems than it causes solutions in your body. The other part is one of the reasons why we don't realize we crave milk, and particularly cheese, is because it's also addictive. So let me just say this really quick. The reason why cow's milk has an addictive property, and there's a substance called casomorphins, and you may hear that morphine. It has casomorphins in it because the purpose of cow's milk, of course, is to grow a baby cow, 1,000, 2,000% over 18 months or 24 months. The only way that a baby cow is going to engorge itself on enough milk in a short amount of time is if there's something in it that makes the cow want to come back and keep eating it. So there are naturally addictive properties in milk, particularly for the purposes that the mother cow wants the baby cow to be addicted to drinking this milk. I need you to keep eating. We don't have time for you to go take a break and go hang out for 2 or 3. I need you to come back and hit this milk. It affects us the same way, which is why most people that try to get off of dairy, cheese is the hardest because that's the highest concentration of those casomorphins. So we don't realize that we're addicted to milk.
which is another reason why I would say just get rid of it altogether, because now we're getting back to, cigarettes, heroin, crack. I mean, what is it that you would advise anyone else that they're addicted to? Alcohol. Why would you tell someone who's coming out of alcohol recovery or Alcohol Anonymous, hey, look, man, moderation, brother. One sip. Just stay away from it. If you backslide, that's okay. So I would advise staying away from milk because it just causes more problems than it helps. You're really not getting any of the benefits that you've been told that you have to do, like calcium or strong bones or all those kinds of things. All those can be debunked. If you're just drinking it because you're like, look, I don't care what you say, I'm going to drink milk. Hey, not a problem. But at least just do it with good information, knowing that I'm drinking it because I want to, not because I need to.
Okay. Now, staying on the milk and cheese thing, there's another question that came through. They asked about the mold factor. Does dairy truly create mold inside the body?
I really don't know about mold. I can't even really speak on that in an affirmative or negative way. I know it creates inflammation.
Okay.
I don't know that mold, the inside of your body, would even have the environment where mold could proliferate. Dr. Brown, is that?
Yeah,
that doesn't sound.
I can't imagine a way it would be that, because pretty much when you eat or drink it, eat the cheese or drink the milk, I mean, you're going to digest it. So whatever's in there is going to get digested. So even if the cheese had mold on it, and you eat it, you're going to digest everything that's there. So no, it wouldn't grow in.
We're talking about, because I know cheese and it ferment. To make cheese, it has to ferment. Correct. So maybe they're asking about the, that since cheese is basically just molded milk, does that, we already know it causes inflammation.
Yeah.
So maybe they're asking.
Yeah, and your body's an ever-changing. You may have heard, you are what you eat. Mm-hmm. And the fact that your cells rebuild and repair and create waste, so your body turns itself over several times based off of what you eat. It recreates, cells die off and become waste. So your body's an ever-changing system, whereas outside, that mold is in a stagnated type of a thing, standing water that never changes. It's not once you put some circulation to it, you eliminate that. So that's probably why mold wouldn't set in your body, because your body's always taking in, processing, breaking down, and getting rid of.
Mm-hmm. Mm-hmm. All right. Another question, since we're on milk, vitamin D. Can you talk about the importance of vitamin D and how much you definitely need to take?
Yes.
Please. Vitamin D, especially with people of color. Talk about vitamin D, please.
Yes. I'm going to talk about this quickly and not get on my soapbox, but I'm very, very passionate about vitamin D. First of all, let me say, in the context of milk, vitamin D does not come from milk. Milk is fortified with vitamin D, because vitamin D is one of the things that helps your body absorb calcium. So the thought is, hey, if I'm already selling you on the fact that you need to drink milk for calcium, let me put vitamin D to it. Now I've got a complete package. Vitamin D is not a part of milk. Vitamin D comes from the best source, UVB rays out of the sun that the cholesterol in your skin converts into 25 hydroxy D and all that kind of stuff. Vitamin D is important for a lot of things: immune function, respiratory health, mood, serotonin, all kinds of things. Extremely important. At this latitude, anything in the United States, pretty much anything above 40 degrees latitude, we only get direct UVB sunlight, a handful of months out of the year. And during those months, only a short time during the day. So every single person in the United States needs to be supplementing vitamin D. First of all, the darker your skin, because keep in mind, originally we're an equatorial people, the melanin in the skin is really a protection from absorbing too much. Therefore, the darker your skin, that means even if you go out at 12 o'clock in July in the sun, if you're standing next to a fair skinned person for the same amount of time, you too will absorb a completely different amount of vitamin D. So everyone needs, I personally, and again, this is for information and education. I personally take 5,000 IU per day, international units. That's what, when anyone asks me, that's what I advise people to take is 5,000 international units per day. It's a fat soluble vitamin. So some people take 20,000 a week, because it's able to be stored. It's not peed out. Like if you take vitamin, a whole bunch of a multivitamin, you pee out the highlighter color, urine. It's fat soluble, so it'll stay. 5,000 IU per day. It is extremely critical. And I'll just make one last point on that. A couple of things that we think that we chalk up to environment. You know how people in cloudy places like Seattle or UK, typically rates of depression and suicide and things like that are higher in those areas, not because it just sucks to live in Seattle, but because they get even less exposure. And vitamin D is a huge component of your mood and serotonin regulation. Also, flu season always comes up coincidentally, not because it's cold, but it always comes up during the point when vitamin D and UVB exposure is less. So the correlation could be made, not causation, but correlation could be made that flu season is because we are now not getting the vitamin D we need, which means our respiratory health absolutely is diminished and our immune system is compromised. In comes flu season, not because the flu is that strong, but because our vitamin D intake is that low.
Great points. Great points. Dr. Brown, you got any things on that?
No, actually, that is, what he's saying about vitamin D is really accurate. So in the medical literature, I'd probably say at least the last 5 years, they have found lots of, yet again, associations with vitamin D deficiencies and a lot of chronic diseases like hypertension and things of this nature. Yet again, not causations, but a whole lot of associations with this. And kind of like you said, I mean, one question about that, is, and yet again, let me go back a little bit before I say that, because even with COVID-19, there's yet again another association with more severe disease with vitamin D deficiency, and yet again, we're not sure what the mechanism is. However, this whole issue of exposure to sunlight seems to be associated with this. So, I mean, if you're vitamin D deficient, number one, you're up in more of these colder climates. Number two, you're probably not going out as often. And, that sunlight seems to have somewhat of a healing, almost a healing property to it. So whether that's the vitamin D creation, or maybe there's something else that's created out there, but like the vitamin D may be a marker. We don't know, but like I said, it does seem to be associated with it. And supplements, like I said, I know sometimes my partner down now, she's Nigerian, and she takes vitamin D, especially in the wintertime. She calls it her happy pill. She calls that her happy pill. So like I said, so it's like we can't associate with it. And it's kind of interesting you said that, because I was listening to, I don't know if y'all listen to Minister Farrakhan, but I do sometimes. But interesting. But it was interesting. He was having a conversation about somebody got on the topic of health, and he was saying how, I guess in, I want to say, was it Caribbean areas? It may not be. It was certain areas of the country and stuff where they basically take a sun bath, like we see white people do. Like they don't, they're not conditioned to not like dark skin. So they go out and quote unquote get a sun bath. So they'll go and, take the shirt off and stuff of that nature and get themselves exposed to the sun. As part of that. And like I said, we don't know what that is, but like I said, remember, we are, we as entities were, we were created, and the more African areas that get a lot of sun. So we just don't, as we stay indoors more, work indoors more, and get less of this sun exposure, we don't know what we're missing out of that.
Mhm.
And so, like I said, this vitamin D seems to be a huge marker
Yeah.
for a lot of diseases. And so, like I said, supplementation is important.
Yeah, it's something that we don't even realize in the animal world. Just as a note, and then we'll get to the next question. Animals obviously with fur don't have exposed skin,
Mhm.
so the cholecalciferol is produced, through in the fur. So when you see animals like licking their fur, that's one of their mechanisms of getting vitamin D because their skin can't produce it. They don't have the skin exposure that we do. And I'm not going to get into this, but there's a theory, you talk about melanation, changes in melanation and where did, those that migrated up to Europe, why did their skin get fair? There's a really strong theory that says it all is because of vitamin D. The melanin had the cells in their skin had to turn around, and basically melanin had to step back out of the way to allow them to absorb more. Because now if I'm here and I get less sun, I need to create a mechanism evolutionarily that I get more. Whereas down here, when I was getting plenty, I need to protect myself from getting too much. So there are some people that think that the color of skin is driven by even vitamin D, but that's not what we're here for. That's I'm just saying it's important.
Next.
It's important.
Next. Definitely. Great information. All right. So the next question comes from Brother Jeffries again. He said, "Can you speak on the consumption of alcohol and how it impacts the body? So many people don't realize how alcohol consumption impacts the physique and overall body functions. Can you speak on that a little bit?"
For sure. So alcohol, first of all, is another one of those things where, hey, if you do it and you know what it does, then more power to you. Let me give an explanation here of alcohol and what it's about. Ultimately, alcohol is a carbohydrate. It's a sugar. The only difference between a can of beer and a can of pop is there's enough ethanol in the beer that's metabolized by the brain that gives you the buzz. Outside of the ethanol component of alcohol that the brain metabolizes, that gives you the buzz, that gives you the one thing that we don't give it to kids for. Outside of that, it may as well be a pop. Your body treats it the same way. Now there's a certain amount, ethanol in the gut is produced, is handled a little bit differently. But all in all, it's a high load to your liver. Now, typically with alcohol, if you're sipping, that's different. You wouldn't take necessarily a hard liquor or whatever to the head like you would, like we'll just down a glass of orange juice. So that's the one thing that makes it a little bit better than pop or juice, is because we typically really sip it and we really aren't taxing our liver and giving our body that load as quickly. But if you are consuming alcohol in excess, you really are just, to the point of a physique, and body function, you're really doing the same damage that you would be doing if you had a pop thing, your pop addiction, or if you're drinking too much pop. You get the same thing. There's fatty liver disease. There's non-alcoholic fatty liver disease. Kids are suffering from non-alcoholic fatty liver disease simply because they're drinking a bunch of fruit juices and juicy juice and Capri Sun and all these kinds of things. It doesn't have the alcohol associated with it, but those lipid droplets that you see alcoholics with in their liver, same thing that people that deal with, non-alcoholic fatty liver disease, same thing, minus the ethanol, minus the buzz. Obviously too much is bad, but typically, depending on what kind of alcohol you're drinking, if you're sipping here and there, you're not doing the same damage like a glass of wine that you may drink with dinner. That's a completely different story than taking, again, a whole 8-ounce bottle of orange juice or Gatorade to the head, where your body has to take all that in at once. So I guess all in all, if you're a sipper, you're really not doing that big of a deal or that making that much of an impact. But if you're guzzling beers or guzzling some sort of an alcohol like that, just taking it to the head, you're really putting a huge load on your liver and on your body.
Right. Cool. Dr. Brown, anything on that?
I think one thing I will tell folks is that, in terms of alcohol, and that is a lot of people like to drink alcohol as a nightcap. And alcohol is interesting. It can help put you to sleep, but it can also interrupt your sleep. So individuals that are having, trouble sleeping, or like I said, they find themselves, they take the nightcap and about 3, 4 o'clock in the morning, they find themselves up, is because of the effects that sleeping effects of the alcohol have worn off. And so it's one of the things that, I feel like no one ever says anything about this. But it is important, like I said, if you're having trouble sleeping, that you make sure that you cut that alcohol out and just see if that helps you to get a better sleep.
Great points. All right, so I'm gonna go get right into the Q&A section. Once again, I want to thank everybody for joining our first Men's Virtual Health Forum, brought to you by us, Columbus Black, TLC, and many more. There'll be more of these. We got a lot of great questions. One I want to get to before we get to the COVID situation, because we know once we get to COVID, there is no coming back and there's no going back, because everybody has their theories and everything else. I want to get to a couple questions. For Dr. Brown, do you need a physical exam every year?
So if you look up the U.S. Preventive Services Task Force, the answer will be no. So in terms of correct. If you are otherwise healthy with no risk factors, okay, those individuals, do they need an annual physical? And the answer, according to them, is no. So if especially if you're just looking for health issues. So like I said, if you have no hypertension, you're not pre-hypertensive, your cholesterol is completely normal. They took a look, they didn't find anything this year. Do you need to come back for the purposes of detecting something next year? And the answer, the evidence-based answer is no. However, kind of like I said before, number one, if you got insurance, like I said, it's probably prepaid anyway. Number two, it keeps you in communication with a healthcare clinician, so you can answer things. Number three, like I said, random things do come up with folks, and that's just so when we do evidence-based medicine, we're looking at huge populations over large periods of time. We can say, hey, yes, on average, a otherwise healthy 25-year-old does not need to go the next year to the doctor for an exam. But what we have to remember is that there's always that one, and that person is not that whether it's a cancer that's being found or something in nature, that person is not counted for when we look from a population standpoint. We're just looking, like I said, sometimes these things are they're policy, where we're looking at huge populations, and that's where that stuff is from. And so from a population standpoint, no, you don't need to, no, you can go wait for 5 years. But from an individual standpoint, you have to ask yourself, what really one of the questions is why not? Like I said, especially if it's already paid for, there is always a chance that I could, something can be found early rather than later. And like I said, and then you also have that relationship that you maintain. So, does it have to be exactly 12 months? No. But like I said, every 1 to 2 years, I would say for most folks, probably so. And then the other thing is this, I think for the African-American man, I think it's a different story, because I think for us, because our culture is not used to the healthcare environment, it is a way for us to interact with that healthcare environment and get used to that. So I think that when you talk about us, it's a different thing. So do we need to? No. but we also have to realize that we culturally are not used to this. And if we wait until something happens, then you're interacting with something that's foreign. Now you know you got a stroke, heart attack, you know, you got whatever it is, and now you're entering into a foreign environment. Is what happens. So for us, I really think for most African American men, yes, no more than every 2 years, you just need to go in there, let them check stuff out. Here you go, I'm here. Mm-hmm. Learn to talk to the nurses, learn to talk to the doc and stuff of that nature, and just get used to that environment. Mm-hmm. So that if something happens, you're not going there for the first time, and this is not foreign to you.
You know, Dr. Brown, something you said reminds me of an analogy, and I know this isn't a one-to-one, so forgive me for this, but we say the same thing when it comes to police. Mm-hmm. So if the only time, and that's obviously we know that's a big thing in our community, right, the only time we interact with police is when we're getting pulled over, you know, and our fears go up because shit, this must be a problem, because every time one of us get pulled over, it becomes a problem. If we were to, and again, I'm making not a one-to-one, but just imagine if we got in the habit, and we talk about getting involved and engaged in the political process and the law enforcement, that's all the same thing. Talking to your police force, going down to, you know, so imagine if we were to, as a community, go in and say, hey, I'm just here to introduce myself. And I'd like to just sit down and talk through kind of what the policies are here. And what, you know, what are your feelings towards me and I towards you, and how can we, so if we had that comfortability in that sense, politically, we only show up for the, you know, elections when it's the presidential elections. Mm-hmm. But we keep telling ourselves, no, show up for your local office, your state office. You stay engaged in the political process so that you're informed and so that you're engaged and you're aware, like, hey, these, you know, things change and it's important. Don't just wait till the big ones, because by then it may be too late. And it's the same thing with health. Don't wait until it's a big one, because then you'll be like, you know, every time I go to the doctor, it's bad news. Mm-hmm. Mm-hmm. And then you're going to be kicking yourself. Had I gone earlier, I would have found. I mean, so it's the similar, not the same. I hate to draw that analogy with social justice and all that, because I don't want to minimize that at all. But that same fear we have is based off of, it's fear based off of, as you said, being foreign. Mm-hmm. Fear from unfamiliarity. You know, you're more comfortable with what you're familiar with. Doesn't mean that you like it. I mean, you may go to the dentist twice a year for cleanings. Doesn't mean that you're like, I can't wait to go. But you're familiar. You're not as fearful. Right. So it's very important that we do that. That's a great point. Great point.
Yeah, we got to remember there's a lot of conditioning that's already implied and already embedded in us that we have to break down. So like the way I always say it, you know, it's always better to be proactive than reactive. So
yeah.
So we need to definitely get to that. So great points. All right, another question that came across. What is the first thing, I guess it's for you, Brother Bailey, I should get rid of in my diet? What's the first thing I should get rid of in my diet? And I know this is a big one. But yeah, just give some suggestions, because you know, that's kind of a broad answer. You know, if you're drinking a 12-pack of Tahitian Treat a day, get rid of that 12-pack of Tahitian Treat. Yeah.
I'm going to go with your answer. I think the first thing that you should get rid of in your diet is not what you chew, but what you drink. Mm-hmm. Fruit juice, soda, Gatorades, those things, because that is 100% sugar water with some vitamins attached, maybe. But what about orange juice? Isn't that good? It's orange juice. It's got vitamin C. Well, so do oranges. Just eat the oranges. Don't drink the juice. Eat the orange.
Let me ask you this.
That would be the first thing is fruit juices, fruit drinks, pops, sugary beverages, anything outside of water, black coffee, and unsweetened tea. That'd be the first thing.
Okay, let me ask you this, pertaining towards juice. What about some of the juice places like Zest, where they give you it's supposed to be nothing but the blended and the cold pressed juice. How about those?
Well, typically cold pressed juice are vegetables, where the sugar content is a lot different than cold pressed apples. Or,
Gotcha.
they may add like a quarter of an apple just for a little taste. So a cold pressed juice is different in the sense that that's normally a vegetable juice, and the sugar content is not going to be as high. The glycemic load is going to be a fraction of what an orange juice would be. So that's different. Smoothie places, or if you make a smoothie at home, typically you're throwing the whole fruit in the smoothie. And although you are, breaking up the fiber some, you're still in a way eating the whole fruit. So, I mean, that's better than fruit juice because you're not extracting. But cold pressed juices are typically like celery, kale, carrots, where the sugar content is fairly low, and they may add in like an apple, a quarter of an apple, just for a little bit of sweetness.
Okay.
And typically those are in a shot. It's not in an 8-12 ounce bottle.
Right.
So that's another big difference.
All right. All right. Back to you, Dr. Brown. Somebody asks, how do I find a proper urologist?
Oh, okay. So number one, get a primary care doc. So that's number one.
Yeah, PCP. PCP.
All right. Get your PCP.
Right.
Because like I said, some of these specialists seriously will not accept you, will not accept self-referrals. I know that there's a pretty large group that's associated with Riverside. And there's a brother, Dr. Eric Ward, that's there. He's the only one I know out of that group. And otherwise, so that's the interesting thing about looking for specialists and stuff of this nature. So you get your primary care clinician. That primary care clinician knows the specialist in that area that they're referring to. So I would know, I work down in Chillicothe, so I would know some specialists down there, but I'm not going to know the ones here because I don't practice here. And the same thing, like I said, so your sources are going to be your primary care clinician to get, kind of an idea, or people who've had urologic services in the area. So basically word of mouth. So those are the kind of the best ways to find them. Of course, the other thing you could do is, there's always that Google search. So if you search Google for urologist near me or urologist in, a certain zip code, it'll come up with a full list of them. And a lot of times they'll have like different reviews and stuff of this nature. The problem I will tell you with reviews is this, and that is, of course, if it's someone that's got like 100 reviews and they're all bad, you got one thing. But people have a tendency to do reviews when they either don't like something at all, or they love something at all. So, if someone's got like, 2 bad reviews and they've been practicing for say 10 years, it's kind of hard to know what that is. Especially if they're, especially since I think for physicians, a lot of times they're just now getting into the habit of, reviewing, what their social media impact is, because this was never part of what we did. Mm-hmm. Our referrals and stuff of the nature typically came from, either in the hospital or from a primary care clinician. So we never had to worry about our online presence. But now I think there's a lot better stuff going on now. Like I said, so, we'll go out and try and get people to give us reviews, but anytime you're searching, just always be aware of that in the back of your mind that, hey, like I said, if somebody's got like a 1.5 star and it's got like 2 reviews, you still can ask about that person. You still want to ask around about that person, but mm-hmm. it may not accurately reflect, that person's practice. So.
Great information. All right. For everybody, I see this question being a question for everybody. Should I be taking multivitamins and supplements? Who wants to go first?
Let me go first at the risk of Dr. Brown coming in and killing my answer. So here's my opinion on multivitamins and supplements. They are good in their place. So the key word is a supplement. So if I say, um, I'll use vitamin D as an example. Some things you absolutely should take. Vitamin D. There's some other things that I 100% think you should be taking each day. Magnesium, iodine, just simply things that you don't get. Sea vegetables that you just don't get, so you have to do it. They become a part of your diet. There are other things that I have an issue with multivitamins because they then become a replacement and an excuse to not eat the real food, the whole food, and the nutritious food that includes those things. So taking a multivitamin is not a replacement for a good diet. So typically multivitamins, I'm for the most part, depending on your age and depending on your scenario, I don't really think that they're necessary. But if you're in a scenario where, depending on what food you have access to, what your age is, what your other conditions, there may be some things that you have a hard time absorbing certain things. You got to take more. So they're okay if you use them responsibly, and they are not being used to replace a good, nutritious, whole food diet. That's my thought on it.
And I would agree with that. For the most part, it's uncommon for most clinicians to, quote unquote, prescribe a multivitamin. Typically, it's probably going to be someone that's older. Sometimes I think pediatricians sometimes recommend them for kids. But like I said, most adults, if you're eating an otherwise well-balanced, varied diet, you should get pretty much most of the nutrients and stuff that you need. And it's always it's better to get your nutrients from the food than the pill, just all day long. So if you can get it from food, get it from the food. So.
Mm-hmm.
And I know in my experience, I stopped taking the pill and I started getting a liquid vitamin just for the resorption rate. I know it's just science that when you take something liquid wise, it's going to go into your system quicker. And so
yeah, and depending on the vitamin, keep in mind that to Dr. Brown's point, certain things, when you take the multivitamin, you're taking the synthetic version of it.
Right.
So to us, when I say us, our mind, we feel we're doing the right thing by our body, but we don't necessarily always know how our body is like, what is this?
Right.
Folate and folic acid, your body responds to, completely different, whereas one comes from the food and another is a synthetic form of the, so that's the other way, or the other reason why, as Dr. Brown said, ideally you get it from your diet. If you need to supplement, there are some things that, when you take it in liquid form are good. I know some people that take some versions of turmeric in liquid form with black pepper extract to it, for absorption, all that kind of stuff. But sometimes you can even take some things in liquid form, and of course they're going to be sweetened and all that kind of stuff. So you be careful that you're not taking
the sugar.
Yeah. Some scissor,
right.
some vitamin syrup. But yeah.
Okay, great stuff. All right, so I guess it's time to dive into it before we get out of here. It's already 11:30.
Let me go on mute.
All right.
Yeah. All right, so the big thing right now, and of course it is affecting everybody across the globe, is COVID-19. So, Dr. Brown, any thoughts on the COVID-19 vaccine? Do you feel it? I'm not going to put you
Go to ask.
in a corner, but everybody, a lot of people feel that it's rushed. One of our people who are on here, they said they're on the front lines. They're a healthcare worker, and they're concerned about the long-term effects. So, I'll give my opinion on it first, since I have nothing, no skin in the game. Nothing's going to affect me, per se. I personally just want people to be safe. I know the history of what vaccines have done to us as African Americans in the past, and from Tuskegee to on before, we've been a lot of guinea pigs, and I'm cautious, but I am open to listen to as well. So, Dr. Brown, can you speak on a little bit? And for everybody, so everybody will know, we are for the next forum we are looking to get a expert on this to speak and and a little bit more with a little bit more clarity on this. And Dr. Brown is definitely can speak on this, but we want to have somebody who can answer those hard questions for you as well, because we're all learning. This just came out, so it's not like it's poof bam. Here's your magic beans. Go about your way. You're good. So we're all learning. But Dr. Brown, can you touch on that a little bit, please?
Yeah, so I think you know what you just said is probably the important part to remember about this. You know, you keep hearing it in the news, and that is the novel coronavirus. All of this is new. This is a new virus that they found, identified over in Wuhan, China, spread around the world. And that was last December when I think it was announced. Yeah, it was last December when it was announced. So, it's a new virus. It's it is the sixth there's a class of virus. There are number of different viruses. Influenza is one. There's a bunch of other ones as well. And this is what we call the coronavirus family. There are a total of six. Three of them just cause a common cold. Three of them seem to be a much more virulent. There was a SARS, several years ago that came, and fortunately, it died out. They actually think it's because it was so severe. There's one that's in the Middle East. That's a similar type of virus that's there, and then we got this new coronavirus that's here. So one of the issues that's happened this year is that, you've heard, you'll hear one thing: wear a mask, don't wear a mask, stay at home. Now we can lock this thing down. But the problem is this, and that is what everyone has seen is science real time. Typically, these sort of decisions are made, and some division or something of nature. They create a consensus, and then they reveal it to the population. Because this spreads so fast, you have seen changes in an order, in a manner that you would have never seen before. The decision would have been made. They just told you, and then they're going forward. And there are lots of different theories about how to manage, this pandemic that's coming through. So that's what has been there, or at least what you've been seeing so far. Now, on the background, kind of like you mentioned, we have our experience in America with healthcare, which is your Tuskegees, which is, Gray Roberts, the whole nine yards, our negative interaction with the healthcare establishment that is there. And that has built a lot of distrust, reasonably so. And now you have a vaccine that is coming out that, you really don't know what to make out of this. And part of it is because it has been created. I think they said, one of the ones that's coming out now is a new platform, which is this messenger RNA platform. And, they basically started working on it in March, April. And now in December, they're telling you, hey, you need to get this brand new vaccine. And I honestly think that I understand a couple of different components. Number one, as a leader, government leader and things of this nature, I want a population to take something that I know they don't completely trust, but I might believe it is helpful. And so therefore you've kind of put out these messages that we're doing this for you. And of course, for us, now they may think this is helpful. We're looking at this like, I don't, I don't know about all that.
Yeah.
And I personally think it would have been better to have formally explained what is going on. So when they say it's safe, that means that, it is safe so far. This is an emergency use authorization by the FDA, which means that the information they've seen from the time they developed it and the trials that they've had so far, they have not seen anything that they think is a harm that outweighs the benefits of being vaccinated. So I think what, at least, and this is part of this is in seeing what I see on social media, because, you'll see people say, oh, it's safe, it's safe, it's safe. It is safe so far. And that's all we can say. That is all we can say, is that it's safe so far. People are like, well, what about long-term consequences? We don't know. It's new. I mean, it's an unknowable. It is an unknowable. And so, like I said, based off of what we've seen, I mean, this is basically, there's something called, messenger RNA that helps to go, that basically, and this is basically what the virus does. It goes into a cell, it releases messenger RNA, or it has you create a messenger RNA that creates a protein. And that's basically what's going in there. And so your body is creating this particular portion of this virus protein, what they call the spike protein. So that, and when you create it, your body will create an immune response to it. So instead of you getting this whole virus, this whole active virus, they're going to, inject you with the materials to make just one component of this virus. And then your body will create antibodies and an immune response to that component of this virus, instead of, what happens when you get the actual infection. And so from what they've seen so far, this seems to prevent, significant illness. They haven't seen anything major, although they have with the Pfizer vaccine. I think there was one incidence of anaphylaxis in Alaska, and I think there one or two in England. And that's just that's an allergic reaction. That's just, I mean, you can't predict allergic reactions. People have those. And so, so you can't get the virus, you can't get a disease, COVID-19 disease, from the vaccine. So that's not what they inject you with. And this platform, what they call the messenger RNA platform, seems to be relatively safe. So that's something that has been studied before. So that's been studied before. What's new is them encoding it with the spike protein from the coronavirus, which is, as far as I can tell, should be relatively safe. So, I say all that to say that, especially for the brother that asked the question that's on the front line. At this moment in time, of course, nobody's mandating anything. I don't even know if you can mandate something that's an emergency use. The military is not mandating it, so I'll put it that way. And so right now it's voluntary. And I would say that, you have to, this is going to be on an individual basis, weighing the risks and benefits. What sort of risk are you willing to put up? Honestly, I just haven't seen anything that makes me, super fearful of this vaccine or anything of this nature. I think it would be good to create the immunity so you don't get infected with the actual virus. Because like I said, that seems to be, like Russian roulette. You may get the version of it asymptomatic, or you may get the version of that lands you on an intubator for weeks. And so, you end up having to make those things. Now, I think that, in terms of risk categories, I would say, if you're 65 and older, you probably want this. I can't see of a reason why you would not want this. I mean, that's, if you ever look at the graphs that show, the proportion of people that basically die from this, it's kind of, it's basically not really existent for the kids. Get to the 20s, you go up a little bit. Once you hit about 65, that line just goes up. I mean, it really does shoot up. So if you 65, you want to get that. Now, if you say you 40 years old, otherwise healthy, I mean, I think, I know a number of people that say, I'm gonna just watch it a little bit and see what happens. But if you're 40-year-old, you're obese, you got diabetes, you're in a high risk category. And, for you got to think about, especially, like I said, if you're, say you're the head of the household, you got to weigh this vaccine where you might feel a little achy for a day or so versus the potential to get an actual infection. And, like I said, it may be that mild asymptomatic, or it may be, or it may be something much more drastic. And at this point in time, like I said, even if it's one of the milder ones, you got to be isolated for about 10 days. So, I mean, I think that there are a lot of things to think about regarding this. And, regarding this, I mean, I think for me, like I said, of course, I work inside a hospital. So of course I've been offered that. Like, my plan is to get it. One of the things I'm seeing now that's making me a little concerned is the fact that, at least my social media is filled with a bunch of 30, 40-year-old, otherwise healthy physicians. And in my mind, I think about the 55-year-old janitor that I feel like needs this before I get it, or at least need to be offered this before I get it. I think about the, like I said, so that's one issue that I'm having right now. So I want to make sure that I'm being either the second or third round before I get that, because I want to make sure that these folks are, the people that need this. Because like I said, you 50 years old, you got comorbidities. I honestly, I understand the apprehension. I do understand the apprehension, but this virus is just different. This virus is, it's way too random. And like I said, once you grab those comorbidities of the nature, its impact on you is just way too serious for me. So that's kind of, I know it's kind of long or whatever, but that's kind of my thoughts about this particular virus. So I think that, it's something to weigh in. And I think if you're a frontline healthcare worker, you gotta weigh those risks. Don't get me wrong, because the thing is, right now, even if you get the vaccine, you still got to wear masks and stuff of the nature. So that's still going to go on. But, you got to weigh how much PPE do you have? I mean, like I said, if you're out there intubating, if you're like an EMS driver, tech, and you're out there intubating people with just a cloth mask, you might want to get this. You might want to get this. You have a high exposure level. But like I said, they got your full PPE and stuff of the nature. You can kind of weigh the pros and cons, weigh those pros and cons. But like I said, right now we're just rolling this out. I think, there'll be ongoing information gathered, and we'll have to see how this works. But I just don't see a lot of. I definitely understand, because, like I said, technically speaking, this is, like I said, it's brand new. It is brand new, so we got to see this. But yeah, so far I haven't seen anything that makes me say, I was a little cautious at first, though. I was like, why y'all want us to take it? But like I said, the more I look into it, I feel more comfortable. The more I look into the research. Actually, honestly, I think one thing that's going to be interesting is that, and like I said, this ability to manufacture, this messenger RNA vaccine thing. I think this because I think it first came about as a way to address cancer, if I remember correctly. Like, you were supposed to be able to develop antibodies to cancers and stuff of that nature. That's kind of a summary, but I think that's where it came from. So it's an interesting technology, honestly. So,
all right, Brother Bailey, how do you feel?
I guess I'm going to say I have no choice, but I would agree with Dr. Brown. One of the things that I want to make sure that I always do is be present, be knowledgeable, and be vocal in the things that I know and that I can defend, and defer to the experts, and defer to those who I would look to for advice in situations where, my level of or my expertise stops and theirs begins. I guess the one thing that I will say, that I would just maybe encourage everyone to think a little bit differently. I personally have not gotten the flu vaccine for, I don't know, a number of years. I've always been of the opinion that my immune system, for the things that we've known, seen, experienced, and deal with on an annual basis, I'm good, and I believe that. And I believe the body's very resilient and will work for you when you give it what it needs to work. So I can't really apply that to this because, as was said, this is brand new. So I definitely would just give the advice, don't just use, well, remember what happened when, as your excuse to not get it. Because I'm going to tie this back, and this may be an unpopular opinion, but I'm going to tie this back to everything that we've talked about. And please excuse my language, with all the bullshit that we eat, drink, do on a daily basis, and we've given no, we do things that have been killing our family for generations, and we don't bat an eye. Vaccine comes out, I'm suspect. You're not putting that in my body. This is my temple. So that's all I'm saying, is be very careful about where you apply the judiciousness of what you will and what you will take in. What you will and what you won't take in. So I defer, and I would go and support what Brother Brown said, Dr. Brown said, because again, I personally know where I like to have a lane and stay in it. And I like to be very helpful and a great resource within that lane. And when something comes up, vaccinations, immunology, I'm going to go to those that I look to as an expert. I can speak on immune system and all that kind of stuff, but the one thing that I would caution everyone to do, don't do things because someone else said don't do it. Don't use, well, because all these other experiments that happened in the past, and they always trying to put something in our body. They've been putting stuff in our body for a long time. You eat it, you drink it every single day, chemicals, so don't get all of a sudden uppity and high and mighty about what goes in your body because it is on the news. That's my only issue with this whole vaccine debate. But defer to your experts. Don't put yourself and your family at risk. If you're immunocompromised, I think you should consider it strongly. We don't know what the long-term effects of COVID-19 and having it would be, as was said. So there's really no historical context to say, what about this? What about that? So I guess that would be my way of skirting around saying, yes, get it, and don't, because I don't want to advise anyone to do it or to not. I would just say, think about why you're really being doubtful about it, and then look at everything else that you doubt and apply that same level of scrutiny. If you don't give a shit what else you eat, drink, you may as well.
All right, I got you.
Honestly, but
I think, and one thing that you did point out that I think is huge, and one of the things that I yet again, the science behind this stuff, I think is okay. I am concerned about these contexts, like when when people don't allow you to ask questions, or if they, minimalize, your concerns, those things are probably much more concerning to me than, quote unquote, whether or not this virus is, vaccine is safe and the science behind this vaccine, and I guess what you would call the politicization, because I'm far more concerned about, precedent, oh, we made this is here, you better take it. Okay, well, I need to ask some questions. And like I said, those questions need, and don't get me wrong, those questions that you have need to be answered. And kind of like brother Bailey said, I mean, like I said, don't, when you're asking those questions, like you ask all the rest of the questions as well.
Exactly.
Question all the rest of your life.
Right.
Because it is. I mean, these questions are a healthy exercise of of our existence, and especially I think yet again, kind of going back to that man. We are providers and protectors of our household and our communities. And, like I said, yes, we should ask questions. We should do our own reading and research as well. And let this just serve as an example, and like I said, you asking about this, but kind of like you said, do I need to eat fat back? Do I need to drink this sugar? I mean, like I said, all that stuff, we need to understand, kind of the impact on all that, because, I think that really is my bigger concern. Is the way this is, I'm okay with nudges, but I feel like there's a push with the vaccine that that seems to belittle our experience.
Right.
Like, I'd sit here and I'm like, oh, when they parade around, the first person with the flag and this, that, and I'm like, well, look, so was Miss Evers. I'm like, so Miss Evers. I'm like, look, so we, like I said, we need to look for knowledge, truth, and not just allow our conditioning to define how we approach this. So,
yeah. Right, great talk. And I mean, it's to touch on that, what Marcus was saying earlier. We put college is a perfect example. When we were drinking in college and we had the Noob juice or the Kappa Punch, or we had the Q oil or whatever we had, and we didn't question what it was, and I know what some of them concoctions were made of, and we put that in our body, and we're still doing it, and we did it with and we didn't do it in small quantities, we did it in huge. Everybody like there's sometimes you just got to check yourself and defer to experts. Even we wouldn't be in this situation in this country or in this if we would have deferred to the experts in the beginning.
I do appreciate everyone's skepticism.
Right.
I'm just really hopeful that just like everything else, interest in politics, I hope that continues. Interest in health, interest in what I put in my body and what you're doing, I just hope that continues. So I like that point that you made, but find an expert, listen to that expert. And I would also just caution in this instance, because I've seen people on social media saying, I'm not getting it. Are you? Or I'm getting it 100%. What about you? Right. I would really be careful about using social media as a way to influence positively or negatively, because you may not realize the amount of pressure or the peer pressure to get it or not get it you're putting on people. Mm-hmm. That could mean someone's life. Mm-hmm. They decided not to get it because they didn't want to appear to be the sellout of the group, and then something happens, God forbid. Or you're pushing people to get it because you believe strongly in it. And something like that decision should be really a personal decision. If you got resources to share, there's some great information that, Columbus Black has, I've seen that we see in the chat. There's great resources out there. But I would just be also cautious about pushing people and pressuring people to do it or not do it. Because even with the information I put out, hey, I'm going to lay it out there, but I try to be very careful about saying you better not, or you better do.
Right.
I'm going to give you some information. I'm going to try to verify it with I'm going to put enough science that that I know what I'm talking about. I'm going to give you enough real kind of average talk so that it makes sense. But ultimately, I'm just trying to help you make a better decision for yourself. And I just advise everyone to do that with this, because this is more serious than, whether I eat 2 apples a day versus 1. I mean, there's a lot more at stake here.
Right.
But I really do not like seeing people almost like who you voting for,
Mm-hmm.
like, hold on.
Like, whoa.
Yeah. So I would just advise, be careful with that.
Right.
I would
All right.
definitely.
We got more questions, but we don't have more time. I wish we can get more into it. Like Marcus was saying, and throughout the chat, Columbus Black has been putting different links in here for you to check out some different information on COVID. The scientist who created the vaccine, she's actually a African American female. She did that. So there's more information on that. But definitely we'll get more into that in the next one. We're looking to have Dr. Frederick to come in. He is an expert. Frederick Berkeley come in. He is CEO of COSI here locally, and we're looking to have him on the forum on our next forum. He is an expert on the matter, the vaccine. So that being said, on behalf of me, Dr. Brown, Marcus Bailey, Columbus Black, TLC, we appreciate everybody coming out to our first Men's Virtual Health Forum. There will be more. 3 hours. We didn't think we were going to go 3 hours, actually. And,
No, we didn't.
And we needed more time. We actually needed more time. So that being said, we know these issues are pressing. We love the conversation. We love the engagement. And there's more to come. Is there anything you brothers want to say before we go?
I mean, just thank you to everybody for tuning in. We really appreciate the interaction and the fact that everybody was interested. Kind of like I said, this was a trial.
Right.
So yeah, but thanks for tuning in.
Yeah, and I'd like to thank you all for your time, Dr. Brown, Brother Chapman. I'd like to thank Columbus Black for participating. Kev, we appreciate your support and pushing it to the community, not just this, but all the great things that you do for the Columbus community. This just wasn't a Columbus thing, but Central Ohio is a key. Everybody knows someone there or is from there or has lived there at some point. So we appreciate what you do to encourage and empower us and our community for what we need to be strong and move forward. So thank you for that. But aside from that, I appreciate the opportunity and look forward to hearing about next time all the comments that come in that says, I took Dr. Brown's advice, I did something, I did one thing, and I feel a little bit better. I look a little bit better. So I'm really most excited just about the one step that everyone who listened will take to improve their health, improve their well-being, go see the doctor that they've been putting off, or go get the checkup that they've been needing. So I'm really most excited about what everyone else takes this information and does for themselves.
I guess. And that being said, there will be a survey.
Oh, my brother from Chi-Town, Brother George Levy, Beta Ada, what's good, man? Hey, appreciate you.
Yeah, there will be a survey after this that we will be putting out for everybody for the next one. This was recorded, so we will be definitely shooting that link out so you can, if there's somebody who needs to listen to this and be a part of this, they can, and we will be putting that out there. And we want to thank everybody for their time, and we will definitely see you next